if you're having problem. Oh, there we go. You ready to go?
Roll. You're good.
Okay. So great. Welcome everyone. We have over 75 people here at conference this morning, and that's very exciting to me because this is biasedly one of my favorite visiting professor of the year. So this is the 12th annual Morgan McHugh Visiting Professorship in Hand Surgery. This fellowship or this lectureship was started in honor of Dr. Ray Morgan, who is on the line. Ray, great to have you here. Dr. Morgan was here at UVA over 30 plus years, was the chair of plastic surgery for a very long time, almost 3 decades, and was one of the hand surgeons that started our hand fellowship back in 1993. And then Frank McHugh, who was my mentor and a hand surgeon in orthopedics and the head team physician for over 40 years. Frank also jointly with Dr. Morgan started the hand fellowship, as I mentioned, in 1993. And that was, they were the foundation of hand surgery at this institution. Back then, it was only the two of them, and now we've grown to 4 orthopedic and 2 plastics hand surgeon, as well as 2 physician's assistants. We expanded our fellowship to 2 fellows in 2010. So we've had 2 fellows for the last 11 years. But this lectureship is in honor of Dr. Morgan and Dr. McHugh. And I want to thank everyone for joining us. Our visiting lecture this year is one of my very close friends, Dr. Warren Hammert, who's a professor of orthopedic and plastic surgery and the chief of the division of hand surgery in the Department of Orthopedics at the University of Rochester. So Dr. Hammert is actually a plastic surgeon, but he is full-time employed by orthopedics, and he runs a very robust, large hand division there at Rochester. He is a very prominent and proud Oklahoma State graduate. Those of you who arrived early, we were talking about the basketball tournament this year, and Dr. Hammert attends the national championships for wrestling every year. He's a very avid wrestling fan. So Dr. Hammert made his name is really in education. He's the education director of the American Society of Surgery of the Hand and sits on council. He's served as the editor of Hand E, which is the electronic educational platform for ASSH. And he's one of the best educators that I've ever come across. He is a remarkable educator, and his research is in clinical areas is quite broad. So thank you, Warren, for being here. It's been a long time. We've been seeing each other in person, but we've worked together in so many different initiatives for the American Society of Surgery of Hand. So, but I'm glad to finally get you here to UVA, even though it's virtual. You were supposed to be our visiting professor last year and everything got shut down, but I'm glad you could join us this year. And for everyone, after Dr. Hammert's 2 lectures, we're going to take a few-minute break, but stay on this link, and we're going to do about an hour or so of case presentations with Dr. Hammert, led by our hand fellows. So anyone who is interested in hand surgery, please plan to stay on the line. So Warren, thank you very much, and welcome to UVA, even though it's virtual.
Well, thank you so much, Bobby. I appreciate the very kind introduction, very kind words, and so thank you. I've really been excited and looking forward to this opportunity, as Dr. Charbra said, since early last year, or maybe the end of 2019, when we'd first talked about this, and obviously things have been shut down. So I'm honored and pleased to be here, at least in the virtual manner this morning, and be able to share some of my thoughts with you about some different topics. So with this, looks everything look good as far as the screen here?
Yep, you're good.
Okay, so great honor, as I said, to be the Morgan McHugh Visiting Professor in Hand Surgery and have the opportunity to spend a little bit of time with you. The first thing I'm going to discuss this morning is our use of patient-reported outcomes in hand surgery. And so as Dr. Charbonneau said, I'm from Rochester, New York. That's kind of a forgotten part of the state of New York, because when most people think of New York, even though you all are not very far away, they kind of think of New York City and forget about the rest of the state. So New York City is down here. For anybody that doesn't know, Rochester is up here at the top. And so we're in what's called the Finger Lakes region, which is this area kind of right through here, named aptly because the lakes are shaped like fingers. Can be a very nice place. This is part of the edge of downtown, the High Falls area of Rochester. This is the Genesee River with a night view of it. And this is one of the Finger Lakes down south in the fall, Lake Canandaigua, which is a beautiful area. We do have a lot of days like this in Rochester as well in the winter. So fortunately, we're past that for now, and it's more of a spring season here. So on to the point of the talk. So from a disclosure standpoint, I have no financial relationships related to this presentation. I think that's always important when you're presenting, because the audience should know if there is at least a potential conflict. And so nothing related to this that's financial. I do like to acknowledge two sources to this. Judy Baumhauer is one of my foot and ankle colleagues, and she has done a lot of work in patient-reported outcomes and really led one of the initiatives here at Rochester to get those started several years ago. As well as the UR Health Lab, which is the area where we actually collect most of our data. And so when you look at outcomes in hand surgery or orthopedic surgery or plastic surgery or medicine in general, historically, these have really been objective outcomes. So for hand surgery, we've always looked at range of motion, grip strength, pinch strength, times for fracture to heal, and pain. And that was kind of good at one point in time, but I would argue that that's not enough anymore. These objective measurements really fail to take into account the patient's perspective, and that's important in 2021 to look at that. And so I say you cannot manage what you can't measure. And if you want to know how the patients are really doing, you need to ask them, and that has sometimes been lost over the years. So why use these patient-reported outcome measures? Well, they incorporate the patient's perspective on how a condition or a treatment affects them overall. It helps us understand their response to medical treatment. And it probably to some degree helps measure value in healthcare. And that's kind of the new buzz over the last several years, value in healthcare. And what this is essentially the outcome achieved per dollar spent. So if you want to improve value, you need to either produce better outcomes or at least demonstrate that your outcomes are good, or reduce costs. It's pretty easy or easier to demonstrate better outcomes for most subspecialties. Hand surgery is somewhat unique in that we can actually reduce cost easier than others. We generally don't have expensive implants like some of our adult reconstruction colleagues, some of our spine colleagues, and we have the opportunity to do cases under local anesthesia in a procedure room for many things, which will help reduce cost. This is an example of the difference in what sometimes surgeons think and sometimes patients think. Judy Baumhauer actually gave me this slide, but this is a comparison of plastic surgeons and patients with breast cancer making decisions. And so if you look at what the patients think is important, it's often very different than what the provider think is important. So from a provider standpoint, breast conservation is huge. 71% of those consider that a priority. From a patient standpoint in this survey, only 7% thought that was important. Living as long as possible, close, but still a significant difference in the thought between the provider and the patient. And the one thing that was really important to patients that the providers didn't think about at all really was the avoidance of use of a prosthesis. And so there's certainly a different perspective at times when you look at what the patient thinks is important versus what the provider thinks is important. So the objectives over the next several minutes, I'm going to talk about some of the principles and terminology used with patient-reported outcome measures, look at some of them that are available and talk about how to choose or some concepts for choosing, and then how to utilize and interpret the data that you actually collect. So some of the things that you'll hear or read when you see articles looking at patient-reported outcomes, responsiveness is the first one. This is essentially the degree that an instrument can detect a change. And so it's really important for determining the difference in the pre and the post-treatment evaluations for the patients. The measurements are generally either an effect size or a standardized response mean. And these are similar. The difference is the effect size really takes into account the standard deviation of an entire population or group, as opposed to the standardized response mean. And this takes into account the changes of those in the study. So the differences within the study versus the differences of population as a whole. When we look at reliability, this is generally looked at as either internal consistency, and that's the items in the scale and how are they correlated, are they correlated effectively. The retest reliability. So is this stable over time? If we repeat this, will we get the same results at 6 months or a year as if we do it now? And then the reliability coefficient. And so the higher number is better. This is comparison between groups. And so the group should be comparable in terms of the results of the study if they are comparable overall. From a validity standpoint, content validity and construct validity are the two terms that we think about. From a standpoint of the content, there's really no gold standard. This can be set by experts in the field. It can be set by patients. It can be set by the literature, but there's not one uniformly agreed measure or agreed method to accept and develop the content validity. Construct validity is a little bit different. It's how well a test measures what it says it measures. So if we're looking at depression, we actually need to use an instrument to measure depression and not look at anxiety as a measure for that. We want to actually make sure we're testing what we're trying to test. Ceiling and floor effects are something that you'll hear about with patient-reported outcomes. And what this is really the ability of a test to measure the extremes of patient populations. So the questions you're going to ask an elite athlete or a college-level athlete is different than the question that you need to know or the information you need to know from someone that's sedentary and oxygen-dependent and essentially homebound. And so if there's a large number of people that fall outside what the instrument can measure, either at the top end, which is referred to as the ceiling, or the bottom end, which is the floor, an instrument is somewhat less than perfect to measure certain populations. Few final kind of key things to think about. The MCID, this is fairly commonly understood as to what it is, but it's the smallest change that a patient can detect and determine as being beneficial. And so identical changes may be different within groups. And this can be established in many different ways. And this is what's often overlooked. It can be a consensus, such as the Delphi method. So this is a method where several experts answer questions and they narrow it down to come up with what is an MCID or an important change. An anchor approach, where you actually ask a patient a question: are you better? Are you not better? Are you worse? Are you the same? Or a distribution approach, which is a statistical method to calculate this. So we look at statistics, and a certain percentage of the population should fall in this range, and based on this, the MCID would be a standard deviation or a half a standard deviation. Concepts along these lines, the MDC, or the minimal detectable change. And so this is the smallest change that can be measured. This obviously has to be less than the MCID. So you have the smallest change that can be measured, what patients perceive as important, and then finally, what's perceived as the substantial clinical benefit. And so this, for example, would be used with an anchor question, and it's not, are you a little bit better, but are you a lot better? And so it's determining something that's really a notable difference for the patients rather than the minimal difference that they can notice. So how does this patient-generated data help us? Well, it helps with empowering the patients and engaging them in their health care. It's been shown that patients that are engaged in this, patients that read their notes in the electronic medical record, that maintain a record, they become more aware of their conditions and behaviors, and they tend to be more in control of their care, show increased involvement in the decision-making. And this is helpful from a standpoint of shared decision-making. So what's the ideal patient-reported outcome measure? Well, there's certain things that I think it needs to have to be effective and easily utilized. It needs to be minimally burdensome on the patient. So easy to complete, precise, reproducible, not repetitive. It's always frustrating when the patients feel like they're having to answer the same question over and over. You want something that has a broad range. So you want a minimal ceiling effect and a floor effect if that's possible. Something that's recognized uniformly. So by the medical community, by the journals that you may submit articles to, and ideally something that the payers would acknowledge. And you'd like something that can be used not only for research, as many PROMs have been in the past, but something that can be utilized for clinical care. The ideal collection process needs to have minimal burden on the patient. So generally I say less than 5 minutes, probably less than 25 questions. Patients don't like to sit and answer questions for 20 or 30 minutes and kind of go through a 100-page questionnaire or 100-question questionnaire. You want something that can easily be collected and stored for both clinical care as well as understanding outcomes if needed for research. So ideally in 2021, you want something that's electronically used. The data can be stored in the electronic medical record and can be immediately available for care with the provider. Hand surgery is different than some of the other specialties. We have a lot of instruments that have been used over the years, and some of them are symptom or condition specific, such as the Boston Carpal Tunnel Questionnaire, the OSCAN, the Australian Canadian Osteoarthritis Index Questionnaire. Some are more region specific, the Michigan Hand Outcomes Questionnaire, the DASH, the PRWE, the PRWHE. And because there's so many, this becomes somewhat confusing when trying to use this for research. So there's not one agreed upon outcomes instrument. If I'm going to do a study on distal radius fractures, I may use the DASH and the MHQ. Somebody else doing the exact same study looking at the same objective information may use the PRWE or the PRWHE. So when you read the literature and you look at a same topic, there may be different instruments. So it makes it very difficult to compare one to the other. And so this is clearly because there's not one ideal instrument and not something that's uniformly agreed upon. So there's so many options. How do you choose really what you want or what you need to get the most bang for the buck, so to speak? So you also need to make sure that you have the appropriate outcome instrument for the correct patient. And I think some of these are clearly really good and important for research and not so much for general clinical care. The Boston Carpal Tunnel Questionnaire is probably a good example of this. It's excellent for measuring carpal tunnel or potentially ulnar neuropathy, but it's not sensitive and specific enough to measure other conditions, trigger fingers, tendonitis, distal radius fractures, carpal instability, other things that we may encounter in hand surgery. And so all of this has kind of led to the recent explosion, so to speak, of the biopsychosocial model. There's certainly a much better understanding now than there was a decade ago over the mental aspects of healthcare and how these really play an important part in treating a patient. We're starting to understand resilience, depression, anxiety, coping skills as being very important. And so we've all taken care of two patients that essentially have the same condition, whether it's a distal radius fracture, carpal tunnel. You do what you see, what you feel is essentially the same operation on both patients. So one of them does wonderful and thinks you're the best doctor in the world. The next one, in spite of having the x-ray show that the fracture's healed anatomically, is doing miserable. They can't do anything. And so, what is the difference in these two patients? There's got to be a mental component to this. And I think we need to understand this a little bit better to optimally treat our patients. Some of the mental health systems, health questionnaires that have been used are listed here: the brief resilience scale, the pain catastrophizing scale, psychological inflexibility and pain scale, and the pain self-efficacy questionnaire. And I've used the catastrophizing scale and the self-efficacy questionnaire some. I have a little bit of insight, but I think the important concept is to understand kind of the mental aspects of healthcare. And that's probably more important for what we do sometimes than the actual physical part, the connecting with the patient and making sure that they are comfortable with the procedure. So in putting this all together, what do you want to come up with? Well, something that's going to look at physical health, something probably that's going to look at least some component of mental health, and then some sort of an anchor question to understand from the patient's perspective, a simple, are you doing better? Are you not doing better? So PROMIS is what I've used quite a bit, and we've had the most experience with here at the University of Rochester. This is the Patient-Reported Outcome Measurement Information System. This is an NIH-funded initiative that was begun in 2004, and they put over $150 million into this. And they've described it as the Roadmap for Medical Research Initiative. It's based on the biopsychosocial approach. And this is domain-specific rather than disease-specific. There's a large bank of questions in each domain, which enables this to be utilized across multiple areas of medicine. And so when you look at the three domains, the physical health, physical function, pain intensity, sleep disturbance, and then there's several additional main domains that can be used for specific medical specialties, such as the gastrointestinal symptoms, sleep-related impairment, dyspnea, things like that, that may be relevant for other areas of medicine. The mental health, the combination of depression and anxiety are the two, but also anger, cognitive function, psychosocial illness, smoking, and then the social health. And if you take all those together and come up with something from each domain, or at least the two most important domains, the physical health and mental health for us as hand surgeons, you can come up with probably a good way to evaluate this. So PROMIS has standardized scores across these domains. In theory, it ranges from 1 to 100, with 50 being the mean for the US population. And a standard deviation is 10 points. So 80% of the population is going to fall within the score of 40 to 60. So 10 points above or 10 points below that mean of the population. A higher score means you have more of that domain. So if you're measuring depression, a higher score means you have more depression. If you're measuring physical function, the higher score means you have better function. And the advantage of this is it allows you to follow patients throughout a healthcare system. And so the patients can see their internal medicine doctor, they can see their cardiologist, they can see their orthopedist. And if they answer the questions at each of these, you can see how they compare. Because they've been standardized, you can get a sense of what their score is and how they're functioning. It uses what they call smart testing, and it's a validated way to collect the data. And so it's based on a statistical model, which is, has two components. The item response theory is used to determine scores, and a computer adaptive testing program. And so what this does is the computer software will give you one question, and based on your answer to that question, will determine the next question. If it says, can you walk a half a mile, and you say no, the next question is never going to be, can you walk a mile? It's, can you walk up a short flight of stairs? And by designing this way, you can end up answering about 4 to 8 questions per instrument, which means the average PROMIS instrument can be given under a minute. And so you can ask 3 or 4 of these and generally get a pretty good assessment of how the patient's doing. So our initiative, which we call UR Voice, the Validated Outcomes and Clinical Experience, is based on the PROMIS initiative. And so we try to get every patient at every clinic and every visit to answer this. This is now this began as an orthopedic initiative several years ago, and now is a university-wide initiative. And that's in part been led by Judy Baumhauer, as I mentioned. So what domains do you want to collect, or do we collect? And certainly in musculoskeletal health, I think you want something for physical function. As hand surgeons, we also collect upper extremity function. And then we collect pain interference. I actually find that one is sometimes more helpful than the physical or the upper extremity function. To look at mental health, depression or anxiety, I think are the keys, and having one of those is important. And we have 2 other things. We have a past question, which essentially is, can you live with your current condition? That helps us understand how well the patient's functioning from their perspective. And then an anchor question. So we ask them how they're doing now compared to their first visit and compared to their most recent visit. And looking at the data we started collecting in February of 2015, this is from a couple months ago, but we have over 277,000 unique patient visits. PROMIS computer adaptive tests for each domain are collected in about 44 seconds. We have a mean of 4 items per domain. And so you can collect 3 or 4 with 16 to 20 items typically. They give me 98.2% of the completion rate. I'm not really sure it's that high based on some of the research that I've done with this, but it's well over 95%, I think, as far as being able to collect it. So quite remarkable that we've been able to do that well. And the key is having kind of a system that doesn't interfere with the flow of your clinic. When you look at PROMIS, the physical function and upper extremity have been shown to correlate with the DASH and the quick DASH. The upper extremity does have a ceiling effect and a floor effect, and physical function doesn't seem to. The physical function and upper extremity actually correlate pretty well with each other also. And so I don't know if there's a proxy. The reason that there is a ceiling effect and a floor effect in the upper extremity domain is because there are just fewer questions. And so you need more questions to be able to separate the differences in people at very high or very low levels of function. And to this point, PROMIS has not been committed to doing that, as there's a smaller group of people, surgeons, care providers that are needing that. The physical function is also comparable across versions. So if you take your score and they've updated or changed the version, you don't have to do anything to change it. For upper extremity, there's a conversion factor as we went from version 1.0 to 1.1 and 1.2. So it makes it a little bit harder to compare older data to new data, but it can be done. So how do you set this up and deliver it? Well, we use essentially an iPad, but you can use any computer, tablet, and it can be done on paper, but probably in 2021, you'd rather have an electronic version. And so when a patient checks in, they get an iPad, they're asked to complete the questionnaire, and they go through, and when they're finished, they hit send or sync, and it sends it directly to the electronic medical record. So we use Epic, which is a pain in many respects, but for this, it's actually been set up and works pretty well. If we're doing something specifically for research, we'll still store that in REDCap. But for clinical practice, all the patients that complete these have their scores stored in the electronic medical record. And the patients can actually view these via the MyChart application here. And so this is kind of what it looks like. We have an outcomes tab that's set up, and so I can click on whatever I want to see. Upper extremity function here, we can see someone that at their initial visit, they were doing okay, close to being within the normal range, and then they've had something that's made them a little bit worse, and they've gone from normal to a mild impairment to what we would describe as a moderate impairment. So how do you use this clinically? We talked about for research, and I think people understand the research implications of this, but in clinical practice, I think it can also be very helpful to understand how the patient is doing. So use this as a communications tool. And I don't say I do this with every patient, but particularly if I have somebody that may be a little bit challenging, I'll try to do this. And so Judy wrote a paper that was published in the New England Journal of Medicine a few years ago, just talking about the whole process of evolution. And we started this based on ACL reconstruction. And we had this kind of complex gait analysis that we used that collected a bunch of data, and it took about 25 minutes per patient. And then we looked at the PROMIS data as we started doing that and realized that within about a minute, we could get as much information that was as accurate with questionnaires as we could with this gait analysis data. And so that was the impetus for beginning things. I say, it's really important to understand the type of patient that you have or the patient that has the disease than what disease the patient has. And so rather than saying, now this person has carpal tunnel, the understanding of that patient itself. So, the extreme examples here, somebody that has done a plank for 8 or 9 hours, I can't imagine that, but that's the world record for holding a plank, as opposed to someone that's essentially sedentary, sits on the couch and doesn't do anything. And so understanding that patient, because what you're going to do to treat them is probably a little bit different depending on what their demands are and what their level of function is. So I look at this often prior to seeing the patient. So I'll click on the outcomes tab. It's the first time I'm seeing the patient and their scores are pretty good. It's probably going to be at least a relatively easy visit. If it's someone I've seen before, I kind of look at the trend and are they moving upward? Are they moving downward? Are they same? And so it gives me a sense of probably how much I'm going to have to spend, how much time I'm going to have to spend with this patient and how to frame my discussion with the patient. So here you can see the beginning. Here you can see at the next visit, which is 6 months later, how they're doing. A couple of clinical examples. Patient with thumb arthritis seen for the first time earlier in 2020, seen 6 months later in the summer, not doing as well. So in spite of the idea that we're going to try some splinting, some exercises, they go away, they come back, they're having more problems. You look at their pain, and now their pain interference is going up. So they're having more difficulty functioning. As I said, this pain interference I find very helpful as far as understanding the psychological aspects of the patient and how they're potentially going to do with treatment. Another example here, distal radius fracture. We can see they initially have an injury, severely impaired, and then as you follow them over a 3-month period, they're kind of back to their normal level of function as they get treatment and they heal. You look at the curve of that and compare that to the mental health or the depression curve. And so even though their physical health was slower to recover, which you would expect, their mental health, once they've had the surgery, they're kind of on their way to recovery. They can at least see the fact that they're getting better. Their therapy is going well. And so their mental health recovers pretty quickly. And in this patient, I've got a pretty good sense they're going to do pretty well following this injury, as opposed to some people that will sometimes take much longer to get better. And this is the health status question. How are you doing now compared to your most recent visit? And you can look at the trend here. First visit, it's not applicable. no change immediately after surgery, mildly better, and then as they continue to recover, they're going to be much better. And so it gives you a sense of patterns for recovery. We've looked at a variety of different things with the PROMIS. This is paper where we looked at depression and pain interference and how it correlated with physical function with this. And not surprisingly, we found that patients with higher levels of depression or pain interference had a slower trend for recovery for the same types of procedures. We've looked at things and how do you have the validity and the responsiveness of PROMIS compared to other questionnaires that have been used historically. This study, we compared PROMIS to the Michigan Hand Questionnaire and the Boston Carpal Tunnel Questionnaire and found that upper extremity and pain interference correlated pretty well with the MHQ total score and the Boston Carpal Tunnel Questionnaire symptom severity score. Physical function didn't correlate quite as well. And one of the things that I think we've really learned in looking at PROMIS, particularly with carpal tunnel, is because the domains that we typically collect don't really look at sleep. And sleep tends to be one of the earliest things to recover following treatment of carpal tunnel or median neuropathy. It may not be the best outcomes questionnaire to use within the PROMIS data to look at nerve compressions. When we look at the MCID, this is going to vary depending on the method of calculation. So rather than thinking of the MCID as a specific number, I like to think of this as kind of probably a range. And it's going to depend, as I said, whether you've calculated this using the distribution method, which is typically half of the standard deviation, or the anchor method, the question, are you doing better now than you were at your last visit? Also think that changes in PROMIS scores and MCIDs are probably helpful for groups for designing research studies, more so than looking at an individual patient. So I don't ever look at a patient and say, well, their score didn't go up, they didn't reach the MCID, this treatment was a failure. I think for individuals, following the trends and directions of their scores are much more important than the absolute change in scores. And this is how I really approach them. You're moving in the right direction, you're getting better. Certainly, PROMIS has some limitations. Other conditions can affect the score, so it's not specific to their wrist injury or their hand injury. And in that situation, they may be doing well, but they fall and they hurt their hip, or they have another problem that can affect their mobility, can affect their scores. It may not be sensitive or specific enough for some of the things we do. Some of the more straightforward things, trigger digits, thumb arthritis even, maybe PROMIS is not the best to collect that. The upper extremity clearly has a ceiling effect and a floor effect. So people at very high levels or low levels of function, that's not the best instrument to use. And then like everything, it's dependent on the patients being honest and accurately completing questionnaires. There have been some studies showing that patients are less apt to be honest in completing mental health questionnaires, particularly if they think the provider is not a mental health expert. So if you're coming to see an orthopedist, they may not see the reason or understand why we want to know about mental health, and they may not be honest in collecting those or filling out those questionnaires. Like everything, there are barriers to implementation. There are other quality measures that sometimes are more important for a given individual, an institution, or department from a compliance standpoint or other. There may be limitations from an IT standpoint. We've been fortunate to be able to implement this here and sync it with our EMR. But initially somebody had to write the code, and that was fairly involved. You need to have the ability to have the iPads or the tablets to actually record this. And so that requires several of them. We use an older version and it's linked. So the only thing that comes up are the PROMIS questionnaires, but there's always a concern. Is the patient going to walk away with this? It would be useless if they walked away with ours from a standpoint of using it. But that's always a concern, and there is a cost to the initial purchase of those. The patients actually need to complete the questionnaires and go through them. The data is not always understood. So initially when we started this, somebody said, well, it's going to disrupt my clinic flow. I don't want to take the time to do this. I'm not going to use it. And so that's certainly a perception. The way that we've set it up where it's completed essentially at check-in prior to the patient getting back to the room has kind of minimized the disruption for most of the providers. So to do this, it really requires buy-in by all parties, the physicians, the administrative staff, as well as the patients. And you have to have the financial resources and other resources to make this work, because it can be challenging to collect, and it takes quite a bit of time and work to get to the point that it's robust and running well like we have done over the years. So I think in conclusion, I'd say we currently don't have an ideal outcome instrument, but PROMIS seems to be comparable for other things in upper extremity as well as musculoskeletal care overall. We need to continue some research to determine MCID and other important metrics within this. And these values are probably likely better for groups than for individual patients. And so what does the future hold? Well, there's been discussion of reimbursement related to outcome for many years. And this seems to change a little bit with every president that's in office. When President Obama was here, it seemed like this was coming very quickly. And then it kind of halted when President Trump was in the office. Hard to know exactly where President Biden's initiative will be, and probably there are more important things for him to worry about right now than this, but certainly that's something that's kind of been talked about and potentially on the horizon. The immediate impact is probably for the orthopedic residents as they graduate and they take their boards. Right now, ABOS is using this for part 2 of their board. So as you submit your case list, they're asking for emails and they're actually sending patients to try to collect data with us. Where they'll go with it, it's hard to know, but certainly there's a thought that this could be used for the continuous certification process in the future. And so the organization as a whole is bought into this, and I think other organizations may, because it's something that can be used effectively for looking at foot and ankle surgery, adult reconstruction surgery, hand surgery, and specialties, subspecialties across orthopedics or musculoskeletal care overall. So that is the end of the part that I have about outcomes. I'd be happy to answer any questions that anybody may have or discuss whatever we can with this.
So Warren, thank you very much. The reason when we were talking about your topics, this one rose to the top of my list because I know, of course, Regis O'Keefe, when he was there, really spearheaded this, and Judy Baumgartner, who's a friend of our department as well, and has was really instrumental, as well as yourself. So, we're in a point here where we have been pushing for this at the department level for years, and we have just been obstacle after obstacle after obstacle from the institution standpoint. We've successfully navigated and negotiated getting the PROMIS module for our EPIC bones, the new platform for EPICs for orthopedics as we transition to our new orthopedic center in January. But there's been a tremendous amount of resistance. Several departments, I've had meetings with general surgery, along with my clinical research team and Joe Hart, who's our clinical research director. We have tried to leverage multiple departments and to convincing the institution to do PROMIS. There's a lot of resistance at the clinic level and the clinic flow. And there's a lot of resistance, to be honest, among the providers because they have busy clinics and they feel like it's going to disrupt their clinics. So you listed a lot of the obstacles, and IT is one of them and so forth. But how long did this take you to really implement PROMIS into your orthopedic clinics? And what was really the factor that accelerated implementation? And then how did you get it across the entire University of Rochester health system?
So we started this, Judy was, Regis was supportive of it when he was the chair here, as you mentioned, and Judy was kind of the driving force. And then we have a health lab at the University of Rochester. And so kind of a combination of those things coming together. So when we started it, Judy's idea was to, get a small group of providers, people that have actually done research and would be supportive of this. And I think, as I tried to lay out, and as you said, there's a lot of providers that are resistant. They don't want to disrupt their clinic flow. We get paid based on RVUs. We don't get paid or, collections, whatever your financial model is, but you're not getting paid on collecting data. So they didn't want anything that would be disruptive. And so it was a matter of being able to set it up in such a way that the providers almost didn't know it was being done. And so when we started it, Judy asked several people, and the foot and ankle division was the first, and hand division was pretty close behind, just based on the way that we had it set up. And so having it put in, having the IT support and having it put in so that the surgeons don't even realize this data is being collected, basically. The ones that are pure clinicians probably don't even know how to find this in the EMR, but the patients get it when they check in. And then it just kind of became a marketing thing. Orthopedics is doing this. Look at the NIH, look at the PROMIS data as a whole. And that was the key to pushing it out to other departments within the institution. And so I don't know exactly, I guess I need to ask Judy that question of how she got the buy-in from the dean and the other people to make it a university-wide initiative, because it was, certainly walking and divisions within orthopedics initially, and over 2 or 3 years, it kind of exploded to become a initiative within the institution.
From what I understand, Regis made a significant departmental investment to actually move this forward, and it wasn't at the health system level initially.
Yeah, no, it was completely within the department and divisions within the department, not even the whole department initially. I mean, there's department funds, but we didn't try to roll it out to the entire department together. It was specific divisions to get it up and rolling.
And then what has it done for your research in terms of research productivity?
So this has really been huge because it's kind of the low-hanging fruit. When things started to come out about PROMIS, there was really nothing there. And so uniquely, Judy would publish a paper and we'd look at what she did and we'd say, okay, we can do the same thing with hand. We can do the same thing with adult reconstruction. And so you take kind of one concept and it becomes a paper in spine, it becomes a paper in foot and ankle, it becomes a paper in hand surgery. And then the residents, once they've done it and gone through, they became pretty good. And so we have some that have been both residents and medical students that have understood how to gather and pull the data. And it just kind of became an explosion of PROMIS research coming out of the University of Rochester. So I think it's been very helpful from that standpoint. I won't say that all the papers that come out are great, but it does help certainly from a residents' perspective, getting them publications, getting them into fellowships. And there are several key papers that have come out in the subspecialties. We did notice also that there is certainly a difference. One of the papers that won an award from an outstanding research perspective in one subspecialty struggled to even get published in a couple other subspecialties. So part of it's because it's new, part of it's probably the difference in the editorial process and what's done, but things that seemed like they should be simple. Sometimes we did hit stumbling blocks because the editors for other journals, subspecialty journals, didn't like it. And maybe it's a lack of understanding. Maybe it's, we were too far ahead, or maybe it's just not perfect for every subspecialty. But it's certainly been helpful from a standpoint of research. But I think the selling point to the university was the ability to use this for clinical care and engage the patients.
Questions, use the chat function and I can provide the question, or please just unmute and show yourself and ask the question. Don't hesitate.
Can you give me some more information about how your residents utilize this information? Do they all have sort of like access to this database, or how do they have access to all of this? Because I think that this really would take our resident research to another level here at UVA.
So what we've done, at least in the hand division, what I've done is I have essentially I hate to say a blank IRB, but I have an IRB to be able to review the PROMIS data. So it gets collected, and initially I would ask for all the PROMIS scores. So after 6 months, I would ask for all the PROMIS scores and all the patients. Now then it's so big that I can't do that, but I say, I want to look at patients that have a diagnosis of this or that were treated with this. So I look at distal radius fracture CPT codes 2560, 7, 8, and 9. I want to pull all the patients that have that. And so they'll give me an Excel sheet that has all the PROMIS scores, and then another one that has all the demographics of the patients. And then initially we had to actually merge those together. And so we had a couple medical students that were very good and residents that were very good as merging those together. And so then it becomes just a matter of managing an Excel sheet and looking at the scores and putting them together into an abstract and subsequently a manuscript. And so I think probably most divisions have something similar, but by having an IRB that's somewhat generic to look at the PROMIS scores, I could pull this at any point in time and not have to go through another IRB for each one. And so that's made it very, very much easier to do research based on this. Does that answer your question?
It does. And so I guess my subsequent question, basically any resident could have a question, a clinical question about a certain condition. You can go back through and look at just massive data on that question, correct?
Correct. So I have the IRB, and then I just need to add that specific resident to the study that we're going to do. And so, there's sub-studies within this, but I have the PROMIS study, and I'll say, I'll tell our clinical research coordinators, I want to pull the data on this. I go to the health lab to get that. And then I say, just add, Matt St. John to this study with me. And so he gets linked in, and that's just a matter of putting in the IRB, because the residents are all approved for clinical research, and, it essentially just needs to be updated in their system.
Nice. Thank you.
Yes.
More questions?
I had a question on the time points that you can pull. So is it different time points, or can it aggregate everything over a certain time frame, or can you look at, for example, like time 0 and 6 months, or 4 weeks, 6 months, and so on and so forth?
What we'll typically do is, if I want to look at a study based on carpal tunnel or whatever the condition is, I'll generally pick the surgical procedure as time 0, so they can look at the CPT code and link that date. So the day they have the 29848 or 64721 becomes day 0. They'll still give me the data before that. So I use the -10 or -30 as the preoperative data. And then everything that we have following the surgery is positive days. And so I can get as much as I want, or as much as we have. There's certain things that, the more data you have, the more the more there is to sort out. But that's enabled us to get a time frame, so we know where we are as our starting point preoperatively, and then a postoperative time point of 3 months or 6 months or 2 years, or whatever we want to look at data for.
Dr. Hammert, that's a very nice talk. I learned a lot. I just have a question about RVU-based, not a collection-based. How is that going to affect faculty get involved in research?
So, I mean, our system, we actually went from a financial model about 4 years ago, from a collection-based model to an RVU-based model. So that's a portion of our salary. Our chair has some discretionary money that, in theory, is more now that we're on this system. I'm not sure I fully understand that, but that's a chair negotiation with the dean. And so then there's an additional amount of money that is available for research and things like that. And so we have a point system, basically. A certain number of articles that get published in a top tier journal are worth X number of points, Y number of points. And then every 6 months we get an academic bonus based on what we've done academically. Did you receive a grant? Is it an NIH or DOD grant? Is it a grant from a local society? And those are worth a certain number of points. Publications, presentations at a regional level, presentations at a national level, are all worth a certain number of points. And at the end of the 6-month block, the chair takes the scores and divides up the money in however way he sees. So it is to some degree arbitrary. You can't say, I'm going to get $200 for every paper that I publish, but you do get at least acknowledged to some degree for the research you're doing. From a pure financial standpoint, you're probably better off doing one more case and getting another 5 or 8 RVUs, or whatever that is. But most people in academics are here because they want to be part of more than just a clinical practice. And so that's what your chairs, anywhere, banking on, is that you're the driven person that wants to do more than just be a clinician, or you would be in private practice. Does that answer that? I don't know if I.
Yes. Okay. Thank you very much.
So if there's no more questions, and Warren, thank you very much for this presentation. It continues to give us a lot to think about here. As I mentioned, we are truly battling trying to get this implemented, and even though value-based pay is very real, and bundle payment initiatives are being implemented across the country, it's been a struggle to get buy-in. And not just at the health system administrative level, but at the clinic level, and even at the provider level. So we'll keep pushing, but hearing how you were able to do this is very, very enlightening for us. So thank you very much for sharing this experience and how you're using PROMIS in your clinics and for your research, because the potential is tremendous. And ultimately, I think you're right. Everyone's going to have to do this if insurance companies require this data for reimbursement. And it's the trend that the country's going in. So we'll move on to your next talk. If you're ready to share your screen there.
Yep, let me.
So this is another topic I chose because it's such a common problem in, obviously in hand surgery, but across our athletic population. It's ulnar-sided wrist pain is so frequent with a lot of our college and high school athletes. So I appreciate you enlightening on this topic.
Bobby, I thought you'd cured ulnar-sided wrist pain. I thought you had a cure for it, right?
One of the unsolved problems in hand surgery, but I think Dr. Hammert, if there's anyone who can solve it, it'll be him.
Great.
So thank you. So this is obviously more of a clinical talk. So what I'm going to discuss now is kind of my systematic approach to at least evaluation of a portion of ulnar-sided wrist pain. So again, no disclosures related to this presentation. And so when you talk about ulnar-sided wrist pain, I think a review of kind of the anatomy and the biomechanics of the distal radial ulnar joint is important. And one thing to always keep in the back of your mind, particularly as I tell our residents and fellows and students that are learning, is remember the ulna is the stable bone of the forearm. That's often kind of the forgotten joint, and the forearm is actually a link of the proximal radial ulnar joint and the distal radial ulnar joint. But the ulna doesn't move. So when you talk about kind of injuries and you talk about someone describes a dorsal dislocation of the ulna, it's really a volar dislocation of the radius because the ulna is stable and fixed. And so the axis of forearm rotation is essentially a line that runs from the radial head through the ulnar foveal region, and the radius rotates around the ulna. And so as you go into supination, the radius and the ulna become more parallel. As you rotate into pronation, the radius crosses over the ulna. And that creates a situation where in supination, the radius is relatively longer, and in pronation, the radius is relatively shorter, or the ulna is relatively longer. And so you can see the forearm rotation here, combination of rotation around and then translation at the extremes with the radius moving dorsally or volarly. And you can see how it rotates around here. And so it's kind of, as I say, a forgotten but very important point to understand that it's all the radius moving about the ulna. The DRUJ is really kind of a sloppy joint. The concavity of the radius is different than the articular surface of the ulna head. So the pronation and supination, or pronosupination, is a combination of rotation of the radius around, as we've described, and then at the extremes, the radius will translate a little bit in a volar direction or a dorsal direction, depending on which way you've rotated, pronation or supination. And so the stability, as opposed to other joints which are very stable, the DRUJ really relies predominantly on soft tissues. And so the TFC, or the triangular fibrocartilage, is really the key soft tissue stabilizer here. This is the primary stabilizer. And if you look at some of the older literature, it became a little bit hard to understand because it talked about when the TFC was tight, when it was loose, and it really has to do with the different components. Depicted here in green are the superficial fibers, and in blue are the deep fibers. And the deep fibers are really the critical ones that are important from a standpoint of stability. And I think our understanding of this really is pretty good now based on some work that Bill Kleinman did and kind of simplifying this now almost 14 years ago. But anyone that's interested in this topic should certainly review Bill Kleinman's article from 2007 Journal of Hand Surgery, because it helps kind of bring a lot of the concepts together and make sense of them. So when you think about the TFC, as I said, there are two components. That's the dark line that comes across here. And in this situation, you can see the superficial fibers that insert into the ulnar styloid are intact, but there's a disruption of the deep foveal fibers that insert here. And so that white spot is indicative of a disruption of the deep fibers. So if you look at the radiology report, this is going to say the TFC is intact, depending on their level of interest and experience in looking at wrist MRIs. And so you need to look at this with a grain of salt, because in this situation, although the superficial fibers are intact, the deep fibers are disrupted, and this can be a source of pain and often instability. So as the forearm rotates into pronation, The dorsal superficial fibers and the volar or palmar deep fibers tighten, and the opposite is true in supination. And this is what allows that final degree of translation after the radius rotates around the ulna, with one group of fibers being tight and the other group of fibers being somewhat loose or lax. And that's what gives you a little bit of play. The extrinsic stabilizers of the DRUJ are important as well. And so the ECU tendon and its subsheath, the pronator quadratus, and the interosseous membrane are very important from a standpoint of stability. And so if the intrinsic stabilizer is disrupted, the TFC, and all the extrinsic stabilizers are intact, it will often still not be grossly unstable. And part of the difficulty with looking at the ulnar side of the wrist is stable is not an all or none phenomenon. There are degrees or a spectrum. And so you can have laxity. There's sometimes where there's gross instability and it's clear, but more times than not, there are degrees of laxity. And so comparison to the opposite side can be important. If you look at the load and how the radiocarpal and ulnar carpal joints are set up, the predominant load goes across the radiocarpal joint. So in neutral deviation with an ulnar neutral or ulnar minus variance, the principal load-bearing axis is over the radiocarpal joint with about 80% of the load there and 20% across the ulnar carpal joint. But this shifts as the ulnar variance becomes positive. And so if you have a situation where the patient is has an ulnar positive variance at baseline, if it's acquired, such as a distal radius fracture where the growth plate and the radius closes. And then there's also dynamic changes. As I talked about, when the forearm rotates into pronation, that radius becomes relatively shorter, making the ulna more prominent and creating an increased load across the ulnar side of the wrist. And so all of these can kind of change what's going on at the DRUJ and the ulnar carpal joint, which is the part of the mystery of what's going on and we need to understand to try to treat these patients better. So with the background in that, the conditions that affect the ulnar wrist, I think you break these down into a couple different categories. TFC categories are kind of the predominantly thought about ones, but there are many other things that can occur at the DRUJ. Soft tissue problems such as ECU tendinopathy or ECU instability. And then problems with the bone, instability and incongruity. And then finally, problems with the cartilage or arthritis. And this is a broad topic. I'm not really going to talk about our DRUJ arthritis. There is a lot of good information. There's actually, for anybody interested, Brent DeGeorge has an excellent presentation on this on Hand-E, looking at DRUJ arthritis. So I'm going to focus on the other ones that are probably a little bit more common. If you look at how we classify TFC tears, we go back to Andy Palmer's seminal article back in 1989, published in the Journal of Hand Surgery, where he broke these down into 4 different types. The type A, or the central perforation, is the most common, is depicted here in the middle. Type B is the ulnar avulsion, so the peripheral tears. Type C are the ulnar carpal ligaments, and type D are the radial tears. And I think this still has merit in discussing TFC tears, but there are some limitations when you look at this classification system. This is just some pictures from Google Images, but when we think about the difference in a central tear and a peripheral tear, the periphery has good blood supply, and so that's generally amenable to repair, as opposed to the central portion as depicted here, where the blood supply is very poor, and so we don't repair central tears, we just debride those. If you look at the more degenerative tears, these are essentially related to ulnar impaction or ulnar carpal abutment. And it's a progress that begins with wear or thinning of the TFC, progresses to changes on the proximal lunate or the ulnar head, perforation of the TFC. Sometimes this can lead to lunotriquetral ligament perforations and tears, and eventually ulnar carpal arthritis. And so, as I said, Andy Palmer's classification is good, but there are some limitations. For example, his 1B tears don't discriminate between the superficial fiber tears and the deep fiber tears. And the deep fiber ones are really the ones that are responsible for most of the stability. And so if you look at this classification system by some Italians, Andrea Tezzi and Riccardo Luschetti, I think this is probably a little bit more detailed and helps us understand the treatment based on where the tear is. So as long as the deep fibers are intact, as you can see depicted here in the first 2, The DRUJ is typically stable and doesn't need treatment. When the deep fibers become disrupted, whether that's a foveal tear in isolation, as depicted here, foveal and superficial fiber tear, or an ulnar styloid that is disrupted at the base that you can often see with distal radius fractures. Most ulnar styloid fractures can essentially be ignored because they're not a problem. But if the foveal insertion is disrupted, that's going to lead to instability, and that needs to be treated. And then the ones where the TFC is not repairable need some sort of a reconstruction. So I'm looking at kind of the other conditions that affect the ulnar side of the wrist. ECU tendinopathy or instability is often overlooked. This is kind of an example of the ECU synergy maneuver, which is, I think, very helpful for determining the difference. The problem with the ulnar-sided wrist is everything kind of hurts because there's multiple structures together. And so on your exam, you really have to differentiate between structures within the wrist as well as structures external to the wrist. And this is effective. What you do is you compress the thumb in either the index or the middle finger. And so for a patient to resist this, they have to tighten their extrinsic wrist stabilizers. So they fire their ECRL and ECRB. And to balance that, they have to fire their ECU. And so if this reproduces the pain without touching the ulnar carpal joint, you kind of start to think their pain is not an intracarpal problem, but it's probably an external problem, such as this with ECU tendinopathy. So they'll have discomfort in this area right here when you force them to resist. There's a variety of procedures to treat this. Patients sometimes will have ECU instability without being symptomatic, but the ones that typically occur following an injury, which I find in more kind of sports where there is rapid twisting of the forearm, golf, tennis, baseball, anything that requires rotation of the forearm with a follow through, they will often have a injury where they'll have popping of the ECU tendon. And so the goal is to keep this from subluxing. There's a variety of different procedures. I'm not sure that one is necessarily better than the other, but you're either creating a sling of extensor retinaculum, repairing the subsheath, or deepening the groove to try to keep the ECU from popping in and out of the groove. When you think about instability of the DRUJ, this is kind of where the crux of this is. It can either be related to a soft tissue problem. TFC is most common, but also ECU in the subsheath if the secondary stabilizers are disrupted as well. An interosseous membrane disruption can lead to problems at the DRUJ. And you can also have bony problems. So a distal radius fracture, a forearm fracture, previous radial head resection for an Essex Lopresti type of an injury, or someone that has an ulnar positive variant. And all of these can cause some degree of laxity and instability at the DRUJ. I like to differentiate this from incongruity at the DRUJ. And by this, I essentially mean lack of a smooth interface between the ulnar head and the sigmoid notch. And this can be traumatic, such as a distal radius fracture, radial head resection, or it can develop over time from degenerative conditions. Rheumatoid arthritis, we know that there's often instability of the DRUJ, and that can lead to extensor tendon ruptures, or degenerative arthritis. But if they have incongruity at the DRUJ, eventually they'll end up with arthritis. So there's probably some merit to treating this prior to that if you can avoid letting them get arthritis at this joint. And even though it occurs, arthritis at the DRUJ is not nearly as symptomatic in many patients as, for example, radiocarpal or midcarpal joint arthritis. So when you're treating patients with ulnar-sided wrist pain, I like to break it down into these three broad categories. And this is something that has really been popularized initially by Dick Berger and subsequently Sanj Kakar at the Mayo Clinic. But do they have pain in isolation? Is there pain with instability or pain with arthritis? And when you ask those questions, then you can generally figure out what your treatment should be. And they're not mutually exclusive. You want to try to identify the location of the pain and then provocative maneuvers that reproduce their symptoms and really look for instability. And so sometimes it's very clear like this, what we're looking at. So this is not something that there's a lot of kind of debate or argument about the instability. It's usually more laxity. But you can look at this where something's grossly unstable, compare one side to the other side and get a sense of, is it just lax or is it grossly unstable? Because the more unstable it is, the more difficult it may potentially be to reconstruct. When you look at your imaging, I think it's important to get zero rotation views. And so by that, I want the shoulder at 90 degrees and the elbow at 90 degrees, because I want to minimize the rotation, the pronation or the supination, because I want to really know what the true length is of the radius relative to the ulna. And then looking at ulnar-sided wrist problems, I always like to get a pronated grip view as well. So I want to know what their ulnar variance is at neutral, and then what their ulnar variance is when the ulna is the most positive. So when the radius rotates across the forearm, and they actually load it to see how much that changes. And so here you can see in the X-ray, the ulna is shorter than the radius, and the alignment of the carpus actually looks pretty good. CT scans or MRIs can be helpful as well. And so in the picture here, you can see the radius is somewhat volar to the ulna. And so there is some good data that demonstrates subtle instability can be inferred on the MRI based on a small amount of difference with the position of the radius in the sigmoid notch of the ulna. And in someone that's had a previous injury, I think full-length forearm views can be very helpful because there's a subtle incongruity that can develop and often be underappreciated. The MRI, as I said, different appearance here. You can see a complete TFC disruption with no foveal insertion, no superficial insertion, as opposed to this where the superficial fibers are intact and the deep fibers are not intact. And some people will say, kind of argue that MRI is not needed, wrist arthroscopy is the gold standard. And I think certainly arthroscopy does have significant benefits, but there are certain things, for example, this patient here, if you're just doing a radiocarpal and ulnar carpal arthroscopy, you're going to have a difficult time determining that there's a foveal disruption. You need to do DRUJ arthroscopy to actually see that. And so in this situation, the MRI is very helpful as far as helping me understand where the problem is. This is a paper published out of the Mayo Clinic now almost 10 years ago, but looking at arthroscopically confirmed detachment of the fovea, and found that the amount of subluxation that you need between the radius and the ulnar head is only about 16%. And so the patients that had documented foveal detachment had an appearance on the MRI that seemingly is somewhat subtle when you look at this, but the difference in the picture on the right in someone with a documented foveal detachment versus someone on the left that has an intact foveal detachment. So when we get to treatment of the TFC problems, the location of the injury determines the best treatment. So for class 1 TFC tears, according to the Palmer classification, as I said, the central tears typically amenable to debridement. The peripheral tears are the ones that are generally going to be repaired. And then the type C or the ulnar carpal tears probably, I guess, are probably more common than are often recognized or appreciated. And the type D tears are probably less common. They probably occur with distal radius fractures quite often, but really less commonly require treatment. In general, my preference for TFC repairs is an open repair, either through the dorsal or ulnar approach. I find it hard to actually get the TFC back down into the fovea if the fovea is disrupted, but I'll use either suture anchors or drill holes. And I think you have to mobilize these for about 6 weeks. We can't accelerate the soft tissue healing to the bone. So when people talk about, oh, I've got a strong repair, I only have to immobilize them for a week or 2 weeks, I don't fully understand that, because your suture is pretty strong, but the tissue the suture is going through, the TFC, is not strong enough, in my opinion, to move these real quickly. So example of an open repair through a dorsal approach, I think this works pretty well. You go through the floor of the fifth compartment, and you're going to anchor that back down to the fovea. And I like this ulnar approach as well. I use that quite often. It's you have to worry about the dorsal sensory branch of the ulnar nerve, but that's the one thing that's in the way. And so here you can see the approach directly ulnar. This is the pisiform, the dorsal aspect of the distal ulna, and I can get the TFC and reattach it to the foveal region with this open approach pretty well. When you look at the outcomes for TFC repairs, I think it's difficult to interpret this because, as I said, instability is somewhat subjective. And most of the time in the literature, the outcomes don't differentiate the repairs of the superficial or the foveal tears. And so if there's a foveal tear and there is true instability, that's different than if just the superficial fibers are torn. If it's a superficial fiber tear, arthroscopic repair probably does pretty well. And in that situation, I'd be fine doing it in the scope. It's just the foveal tears that I think are very difficult for me to repair arthroscopically. As I said, the type 3 or the split tears, I guess, are probably there, at least in the Mayo Clinic's experience, more than we would realize. This is a paper from the Mayo Clinic a couple years ago, looking at 96 patients over 10 years. So not super common, but 10 a year almost, that were diagnosed and repaired arthroscopically. And kind of I put this in here just to say, keep in the back of your mind that these tears do exist and may be a source of pain that is underappreciated. As we think about ulnar impaction, this is kind of the class 2. And so now we're back to, what do you want to do as far as evaluating these? You need the zero rotation views looking at the ulnar variance, because that's going to be helpful. And then your treatment is really going to come down to doing something to unload the ulnar carpal joint. And this can be done with an wafer procedure, removing just a distal portion of the distal ulna, or an ulnar shortening procedure, either in the diaphyseal region or the distal metaphyseal region. So work up, as I said, the zero rotation PA and lateral pronated grip view. I still find MRI helpful overall, but we'll still proceed with arthroscopy. If you have a patient like this, where there's kind of clear changes in the proximal ulnar aspect of the lunate, the ulna is longer than the radius as depicted here, less need for an MRI, but still patients are sometimes sent with them. And so MRI, you'll see the classic findings here with changes in the proximal ulnar aspect of the lunate. I always like to tell our residents and fellows and students that, evaluate the image yourself before you look at the report, because a lot of times the radiologist will not be an expert, and they may call this Keen box rather than ulnar impaction. And obviously the treatment for Keen box is very different than the treatment for ulnar impaction. And here you can see on this view here where the radius is sublux fotally, this is more than the 16%. So something that's going to be indicative of instability at the DRUJ, in addition to the ulnar impaction that they have. Wafer resection, I generally reserve for somebody that's a fairly low demand patient, maybe a smoker or someone that I'm concerned about the ulnar osteotomy healing. But here you can see the example depicted where we've debrided some of the distal surface of this, still maintained the articulation of the sigmoid notch, but unloaded the ulnar carpal joint in this manner. The role of arthroscopy, here you can see the central tear before and after debridement here. The idea behind this is to kind of clean up these frayed edges and hopefully decrease some of the synovitis and inflammation within the joint. If you look at this paper out of South Korea from a few years ago, they looked at arthroscopy and TFC debridement, European Journal of Hand Surgery. They found at a year there was not a difference whether you proceeded with arthroscopy at the time of ulnar shortening, but they seem to do better in the short term in the arthroscopic group. So if I have someone that has ulnar impaction that I'm going to treat with a ulnar shortening, I will scope the wrist at the same time and debride the TFC. It enables me to look at the lunar triquetral ligament and have a better understanding of what's going on inside the joint. From a standpoint of shortening, you need about 2 to 2.5 millimeters. This has been demonstrated to change the load across the radiocarpal and ulnar carpal joints. If you can get back to an ulnar neutral variance, as we talked about initially, about 80% of the load comes across the radiocarpal joint and 20% of the load comes across the ulnar carpal joint. And so I use this kind of number in someone that does not have a previous injury. Someone that, for example, has had a distal radius fracture that's healed with shortening, then you probably need to come closer to creating an ulnar neutral variance. But in someone that has not had a previous injury, shortening about 2 to 3 millimeters is generally adequate regardless of their preoperative ulnar variance. It's a paper that looked at cadaver models. And so as I said, in an ulnar neutral wrist, it makes sense to shorten them 2 to 3 millimeters. But remember, the ulnar carpal joint is somewhat dynamic, and the position of the wrist, whether it's inflection, ulnar deviation, radial deviation, or pronation, is going to determine the load across the joint. And so if you look at this cadaver model published from the surgeons in Canada in 2019, they looked at the load across the ulnar carpal joint. And the take-home point, this is a fairly busy slide, but if you look at red as being the ulnar carpal load, blue being the radiocarpal load, in almost any condition, if you shorten them between 2 and 3 millimeters, you're going to unload that ulnar carpal joint enough that it takes care of their symptoms. And so that's where I think the 2 to 3 millimeters is clearly supported outside of a traumatic injury or a traumatic change in ulnar variance. So when you think about the ulnarostomy and shortening this 2 to 3 millimeters, it can be done either in the diaphyseal region, which is the traditional approach, or in the distal metaphyseal region, which has been popularized over the last 12 to 15 years. The diaphyseal region, as I said, is much more common. It's an extra-articular procedure, but it's through diaphyseal bone, and so this can generally be much slower to heal. There is prominent hardware, often requiring removal, some studies over 50%. It tightens the ulnar carpal ligaments, and I think this is the big advantage. Someone that has kind of mild laxity at the DRUJ and not gross instability, maybe you can avoid doing something at the TFC by shortening them in the diaphyseal region. The distal metaphyseal region, not as commonly done. It's an intra-articular procedure, but it's through metaphyseal bone, so it generally heals quicker. There's less need for hardware removal because it's not prominent along the ulnar aspect of the forearm. The downside is it probably doesn't tighten the ulnar carpal ligaments as much. And so when I'm deciding between these procedures, I really look at the laxity that they have at the DRUJ to help make the decision. So clinical example here, patient with an ulnar positive variance, you can see that increases with pronation and grip on the right. Diaphyseal shortening, when this was initially done, hardware was more prominent. Now that there's commercially available systems that create compression across the osteotomy site, generally with an oblique cut, I think the non-union rate is probably less, and the delayed union rate is probably less than it used to be, but still can be a problem. If you look at prognostic factors, looking at union after ulnar shortening in the diaphyseal region, this is a paper from JBJS about 4 years ago. Looked at 325 patients, about 10% had a delayed union or non-union. Things that they found that were related to this: smoking, low bone mineral density, and decreased wrist motion beforehand could be indicative of that. One thing that I was kind of surprised about is a double saw cut. And so some people, to try to increase the width of the cut, will put 2 saw blades on, but that was actually predictive of delayed union or non-union. So that's probably the big take-home point for this. If you're going to do an ulnar osteotomy, you may be better just using a single saw blade than trying to increase the width of the cut with a double saw blade. Systematic review from a couple of years ago in the Journal of Hand Surgery evaluated 37 studies, over 1,400 patients. The non-union rate was actually lower than I thought. It was 4%, irrespective of the orientation of the cut, and delayed union even less, so under 6%. So if you look at all the studies, it's not as high to have the rate of non-union or delayed union is not as high as I would have thought about. Always a question about the obliquity of the DRUJ. Does it matter if it's a neutral DRUJ, a oblique in the radial direction, or a reverse obliquity in the ulnar direction? Does it really matter? And I think most people, as they look at this, would say it probably doesn't matter. There may be a little bit of a change in the load across the DRUJ, but in terms of outcomes, even the reverse obliquity cut as depicted here in type 3 probably doesn't make a difference. And I think most surgeons don't necessarily avoid something based on that. Here's an example of the distal metaphyseal osteotomy. You can see the changes in the proximal ulnar aspect of the lunate, the increased variance with pronation and grip. It's done through essentially the same approach as you would to repair TFC. It's through the 5th extensor compartment. Here we're putting K-wires in to orient where we're going to make the cut. It's just proximal to the articulating portion at the sigmoid notch. And this is essentially a radial closing wedge osteotomy. So you're taking out a portion of bone that's thicker on the radial side than the ulnar side. You want to avoid cutting through the ulnar cortex, or you'll create an unstable distal ulna or ulnar head, and that can be a problem. But it's fixed typically with just one headless compression screw. So the reason you don't need to remove the hardware very often is it's essentially an intra bony screw as opposed to a prominent plate and screws along the ulnar aspect. If you look at this biomechanically, paper Jeff Greenberg did several years ago with the group at Syracuse, they looked in a cadaver specimen to look at the forces across the radial ulnar joint with transverse compression, and found that there was a significant decrease in the load across the ulnar carpal joint. The changes from a mean and a maximum standpoint decreased regardless of the position of forearm. And with this, even though you're closing it down, there was no significant changes in the load across the distal radial ulnar joint. The place that I think this is probably the best and has the most application is someone that has had, for example, a distal radius fracture, a teenager, their distal radius has closed, their ulna is becoming longer. You can close down the growth plate and you can shorten the ulna at the same time. So it's a patient with symptoms from ulnar impaction. As I said, the kind of key points, you want to make your distal cut first rather than your proximal cut. Once you make the proximal cut, it's harder to stabilize that distal piece of bone. Don't cut through the ulnar cortex. You want kind of a green stick type of fracture. And then a reduction clamp and an anti-rotational K-wire. So as you place your screw, it comes out in the appropriate condition here. So here you can see patient 3 months, excellent wrist motion and forearm motion. We looked at our early series of these, published this in the Journal of Wrist Surgery back in 2014. And essentially, patients were very comparable from side to side with no significant differences. So if there's an ulnar positive variance and a peripheral TFC injury, how do you decide what to do? Do you want to repair the TFC? Do you want to shorten the ulna? They both have kind of advantages and maybe potential disadvantages. But repairing the TFC creates an anatomical insertion site for the TFC. One of the things that I think happens when patients have an ulnar positive variance, they often adapt to some degree and they create some laxity. So as they pronate their forearm, the radius and the carpus tend to translate a little bit more volarly. So when they ulnarly deviate, they don't bump into that. And so if you repair the TFC and you tighten that, you may extenuate ulnar impaction and they may develop symptoms of ulnar impaction down the line. If you shorten the ulna, it probably does tighten the ulnar carpal ligaments enough in most cases, but it doesn't restore the anatomical position of the TFC. I also find that talking to a patient about cutting a bone and shortening it seems to be more involved, and they think of this as a much bigger procedure than repairing the TFC. The TFC repairs, as I said, require mobilization above the elbow. So from a patient's comfort standpoint, it's more of an issue, but less chance of having a problem. If you cut a bone, if they break the bone and it doesn't heal, usually you're okay with that. But when you cut the bone and it doesn't heal, it becomes a much bigger problem. So that non-union rate, even though it's low, can be a substantial problem. Or do you need to do both? You need to repair the TFC and shorten the ulna at the same time. If you look at this paper out of Duke, where they compared arthroscopic repairs and ulnar shortening osteotomies, retrospective study, so some limitations, but they found there was no significant difference between the groups in terms of motion, DASH scores, and visual analog pain scores. The ulnar shortening osteotomy did require 2 additional procedures, one for hardware removal, and there was 1 non-union, which when that complication occurs is a big problem. So let's move on and talk about instability for a bit here. When you think about instability of the DRUJ, this can be problematic. And as I said, foveal ulnar styloid fractures generally can be ignored, but if it's an ulnar styloid fracture where the foveal fibers have been disrupted, this is something that's a different situation and requires some treatment. So here you can see the MRI with this. The foveal disruption has occurred and it's still attached to the ulnar styloid. In a situation like that, you can actually repair the ulnar styloid and that'll take care of the instability there. And so I like this when it's possible because bone heals to bone sometimes easier than soft tissue heals to bone. And you don't have to immobilize them above the elbow. I'm more comfortable letting this person move early on than if I've done just a TFC repair. One thing I think we always need to think about is the previous forearm fractures. And so a lot of times kids will have fractures, they're treated, they heal, and it's kind of forgotten about. And unless you ask, well, I had a fracture when I was a kid, it just was managed in a cast, it's not a problem. But sometimes this can lead to problems at a later point in time. And so sometimes things are clearly obvious that there's incongruity. Here you can see an example of a patient here actually came and presented with what was looking like a ganglion cyst along the volar aspect of the wrist. And when you look at this and you see the alignment of the DRUJ and the arthritis there, you can see, okay, this is kind of why the problem is there. But you need to look at the forearm. And as we get the forearm here, you can see the radius is straight. We know a radius should have a curvature to it. And here you can see kind of where the bend is in the radius. And this was result of a bony problem rather than a soft tissue problem. And so if there's incongruity, you've got to correct the underlying cause with the radius osteotomy or something to correct the bony alignment. And so that's where the full length forearm views can come into play. Because any soft tissue procedure, prosthetic arthroplasty, is going to fail if you don't have essentially close to anatomical alignment of the DRUJ. So trying to repair the TFC or do a DRUJ reconstruction, or if they have arthritis, trying to put an ulnar head in, or even a DRUJ prosthesis is going to fail if you don't have the appropriate bony alignment. So here in this situation, you can see the early films with the radius now in appropriate position and the DRUJ aligned. So if the arthritis was symptomatic enough to do something, you have ability to treat this in a different manner rather than just resecting the ulnar head, which can be problematic. So here you can see the alignment of this is healed. And this patient, actually, the DRUJ arthritis was not symptomatic enough for intervention after we did this. Sometimes it's very clear like that patient, but sometimes it's fairly subtle. And so if you have a situation where there's suspicion of instability or something that doesn't quite make sense, I think getting a CT scan with three-dimensional modeling can be very helpful. So this is an example of a patient that if you looked at the full-length forearm films, they look pretty comparable. And so then you look at the CT scan and you say, well, there's probably something going on here in the ulna. Maybe this is the reason that the DRUJ is unstable, comparing the asymptomatic side to the symptomatic side. And so in trying to figure out how do you want to treat this, you can actually model and superimpose the normal side on the abnormal side. And so in this situation, in spite of the ulna looking like there's a problem, the ulna lined up very well. But what you can see is the radius did not line up as well. And so the blue is the asymptomatic side. The white is the symptomatic side. And here you can see a difference in where the ulna, the radius is distally. Normal congruent alignment at the proximal aspect of the radius in the ulna, but as we move distally here, so you can see that there's a subtle forearm malunion that's resulted in instability. So you've got to correct the underlying bony problems and then repair the TFC if needed. Soft tissue reconstructions to stabilize this will not be successful unless there's normal bony alignment. But with normal bony alignment, there's different reconstructions that can actually be very effective. And so this is a situation where a patient had had instability of the DRUJ, had had a couple previous TFC repairs and still was unstable. And here you can see again, this is not, even though there is some subjectivity, clearly qualifies as unstable if you look at the difference in the translation between the radius and the ulna. Another thing that's important to look at is the shape of the sigmoid notch. If you have truly a flat-shaped sigmoid notch here, this is the Tolot classification, but different than something where there's a C-type curvature is depicted below, or a ski slope curvature, an S-type curvature, because those are going to help impart some degree of stability at the DRUJ from a bony standpoint. So here you can see the TFC is disrupted in this situation, probably not repairable, and really a flat bony prominence at the sigmoid notch of the distal radius. So in this situation, in addition to the soft tissue procedure, I'm going to try to change the alignment of the distal radius just a bit to create a little bit more of a curvature there to try to keep the ulnar head in the appropriate position. So this is the Adams-Berger reconstruction. In my mind, this is the best for soft tissue reconstruction because it reconstructs both the dorsal and volar limbs of the TFC. And here you can see kind of the depiction of how this tendon graft goes through here. Here you can see a clinical example of this. We're going to approach this from a dorsal and a volar approach. The drill hole is made through the radius to pass the tendon graft. In this situation, we're going to do the osteotomy along the volar side to try to help increase the curvature and provide a little bit more stability. Here you can see the initial postoperative x-rays. You can see where the bony cut is with the drill hole right around that. And here you can see further healing. Here you can see the hole that's healed through the ulna where the tendon graft has been placed. And here you can see early outcomes, a little bit of stiffness with rotation of the forearm. You can see the supination on the affected left side is not quite as much as the right side, but reasonable rotation of the forearm. And here you can see the forearm x-rays on the left side compared to the right side. A little bit of a different position, but after the reconstruction. So putting everything together that we've talked about, I think this paper that Sanj Kakar and Mark Garcia Elias published now about 5 years ago is really an excellent way to think about this. And they've described this as the 4-leaf clover treatment algorithm for ulnar-sided wrist problems and DRUJ problems. And you can have a problem with the bone deformity like we talked about, or radius malunion that's contributing to problems. You can have soft tissue problems such as the ECU being unstable to cause ulnar-sided pain. You can have a TFC problem, or you can have DRUJ arthritis, which is the cartilage defect. And these are not in isolation. Sometimes there is a combination of things, as you can see where these circles cross over. And so even though each of these circles represent one condition, you may have multiple conditions that you need to treat. And so depending on whether it's a bony problem, a TFC problem, a ECU problem, or an arthritis problem, you'll determine what is going to make the most sense for treating the patient, give them the best chance to have a reasonable outcome. As I said, the DRUJ arthritis is a whole large topic in of itself, so I haven't covered anything along those lines just because this is a fairly long talk without that. But another issue that chronic ulnar-sided wrist problems can develop. So thank you for your attention to this. Hopefully you've got at least some new ways to think about things and approach the ulnar aspect of the wrist. So I will stop my sharing here and be happy to answer any questions that anybody may have.
Thanks, Warren. That was incredibly comprehensive, and it shows why we've struggled as a specialty to deal with ulnar-sided wrist pain, because there's so many different aspects of it that can be pain generators, whether it's, you know, TFCC tearing or instability or arthritis or deformity. Do you ever just, for ulnar carpal impaction, do you ever just debride the central tear and burr down the ulnar head? I don't ever do that, but a lot of people do that as the ulnar shortening portion of it. I prefer to do all mine diaphyseal because it tightens the ligaments. But do you ever do that if you're staring at the ulnar head through a TFCC central tear?
It would be very rare. And the reason that I guess that the patient that I would do that in is somebody that's a heavy smoker that I'm really concerned about in non-union with the osteotomy. I said it, you know, it's one thing if they fall and break the ulna and it doesn't heal. It's another thing if I cut it and it doesn't heal. And so someone that I'm really concerned about them not healing was really probably the only time that I would think about doing that. And you can only shorten it about 2 to 3 millimeters. So you're limited to what you can shorten with a wafer procedure. The other thing that tends to do is the ulnar head's a raw surface that bleeds. And so I think that takes them a bit of time to recover because they do get bleeding in the ulnar carpal joint. That causes some discomfort and that slows down their kind of rehab and motion. So never say never, but certainly unusual that I would approach it in that manner. I like to shorten it. And if they are lax or unstable, then the diaphyseal shortening is what I would do. If they're really not lax at all and they're just ulnar positive, then I like the distal metaphyseal because I think that's a shorter recovery, tends to heal faster overall.
So questions from our hand surgeons?
Yeah, Warren, it's Brent George. Thanks for the talk. That was excellent. Awesome review. In linking your first talk with this one, how do you think that patient-reported outcomes with ulnar-sided wrist pain compare with some of the other common complaints that we see in hand surgery, like radial-sided wrist pain, thumb basal joint arthritis, and some of these things? It seems like ulnar-sided wrist pain can be truly debilitating, and many patients often go through multiple subsequent procedures after their index procedures for instability and things. I wonder if you've looked at that specifically.
Well, we actually did look at our patient-reported outcomes for isolated groups of ulnar impaction. I think, as you said, the diagnosis and treatment of radial-sided problems is generally more straightforward because there are less things that are there. You think about it, it's often, basal joint arthritis, de Quervain's, tenosynovitis, or if it's something in the wrist, either slack pattern arthritis or a scaphoid injury, as opposed to the multitude of things on the ulnar side of the wrist, lunotriquetral ligament problems, pisotriquetral arthritis. And so part of it is just figuring out what the diagnosis is. And so it's hard to have a good outcome if you're not even sure what your diagnosis is. And so I think it's probably harder to evaluate that because you can't lump them into kind of 2 or 3 diagnoses. There's so many kind of things and more of a spectrum of symptoms within some of the ulnar-sided things. But we looked at our outcomes with ulnar impaction, with ulnar osteotomy for ulnar impaction, and we're able to do the same thing there, but it was a small subset of patients that have ulnar wrist problems as opposed to encompassing the whole kind of diagnosis or the whole area as a whole.
Totally agree. It's such a complex spectrum of diagnoses. It makes a lot of the subsequent investigation tough. One other question is that you had mentioned UT split tears, and having trained at Mayo, we diagnose those fairly commonly, but I've seen them less in my practice here. I don't know if it's a Rochester, Minnesota thing. How do you like to look for those? Is it you use MRI to evaluate them, or how do you pick them up?
So this is one of those conditions I say it's probably seen me more than I've seen it, meaning that there's probably many that I've missed over the years. And I'm certainly more aware of it now just from talking to the people at the Mayo Clinic. I think the way that I can diagnose this is on arthroscopy. I've never been able to clearly or confidently look at an MRI and say, yeah, that is. Even when I look at or I talk to the people from the Mayo or look at some of the stuff that Sanj Kakar has presented and talked to him about that, oh yeah, it's right there on the MRI. I don't have the ability to see that. And certainly our radiologists don't have the ability to kind of read that. I've not ever seen them kind of describe that. I'm not sure if they're even aware of that as a condition. So I think it's really arthroscopically evaluated for me. And it's really a matter of actually that probe going in and there being a clear kind of tear between the 2 sides. And so I've repaired some of them. I'm not sure that I have the perfect answer, and my outcomes aren't nearly as good as what they described in that paper that I referenced from a few years ago. Maybe it's because I'm not as good at repairing them. Maybe it's because there's something else that I've missed. I also think, at the Mayo Clinic, there's to some degree a placebo effect. And so when patients come there, a lot of the time, probably as you would admit, they've kind of been treated elsewhere. They're kind of feel like this is my best hope to get better. And so sometimes they get better just because of the psychological aspects, as opposed to doing something actually different when you're in Minnesota than when you're in Virginia or when you're in another state.
Thanks, Warren. Totally agree. That's what I told myself during my first year of practice to make myself feel better when things weren't going as well.
So, Warren, do you do anything on the sigmoid side? Our last Morgan McHugh visiting professor was Sanj Kakar. So we heard some things, that was several years ago. That was almost two years plus years ago, I guess. But do you do anything to deepen the groove? Do you do osteotomies? Do you do the meniscal transplant that Sanj does to deepen the sigmoid notch and stabilize the DREJ? What is your experience with that?
So I've done the sigmoid notch osteoplasty that Brian Adams has kind of talked about and popularized. I've never done the calamari procedure that Sanj and Bassam have kind of published. And to some degree, I think that makes sense. I think that I just haven't had the right patient to do it in. The cost of the meniscal allograft is not cheap, and so that adds a fair amount to the cost of the procedure. At least from what I've looked at our institution, it's about $7,500 to get that. Now, maybe it's because it's often size matched and there's a piece of bone with it, and I don't need all that, but I haven't found a cheaper way to get that. So I'm intrigued by it, but I have no clinical experience with it to say this is going to be helpful or is it the right thing to do. But I understand the theory and the concept behind it makes sense to me. I just haven't done it yet. Have you had any experience with that, or anybody at yours?
I've done it once. I mean, Brent may comment on it since he did his fellowship at Mayo. Brent, what was your experience with that meniscal allograft to deepen and stabilize the distal ulna?
It's something I haven't done here since being there. You know, anatomically, the shape of the meniscus graft was nice in that it did cover the ulnar head, and oftentimes they would combine it with a DRUJ pyrocarbon arthroplasty using like a third, or using a metacarpal head implant, which is also kind of out there and off label. Yeah, I've done also the osteoplasty that Warren talked about from the volar side to try to improve the curvature of the DRUJ. I think that's a more stable or predictable procedure, at least in my hands. There's a lot of exposure required to get that meniscus in there and to secure it with anchors and such.
I always joke around with our residents and who are interested in sports and our sports faculty that everything I do is just like an ACL repair. And the Adams procedure is exactly that. It's like an ACL reconstruction of the distal ulnar joint. And we use meniscal allografts in wrist surgery, and we do scopes. So it's essentially doing sports. So that's why I wanted this topic presented, because I figured there'd be some interest across the board from our residents and faculty. But it's a complicated problem. It's just always not a good solution. But your point about correcting the bony deformity is absolutely critical, because the soft tissue procedure alone will not solve the problem in that setting. And I think it's often missed or not addressed, and the soft tissue stabilization of the distal ulnar joint fails because that is the case.
Yeah, I think it's those subtle previous forearm fractures that are underappreciated, and sometimes you don't even think to ask them about it, or it's so long ago the patient doesn't even think about it. But a fracture at the epiphysis of the radius when they're 14 becomes a midshaft angular deformity when they're 24, and it's just not something you see in your wrist x-rays, and it's something missed if it's not specifically investigated.
Great. Any more questions?
Warren, Ray Morgan, thanks very much.
Hey, Ray.
Are there athletes that do well and athletes that don't do well on the ulnar side? I noticed there was a girl in Texas 2 days ago, pitched a perfect softball game, struck out 21 consecutive batters. I can't imagine the strains on that wrist.
Yeah, I'm sure there are different sports. You know, you think about the torque that golfers have now. I mean, these, golfers, the amount of torque that they have, the swing, the follow through with that, not only does it create problems for their back, I'm sure it does create problems to some degree for their ulnar side of their wrist. I don't, I guess I'm fortunate where I am that we don't have high level athletes here. So I take care of a lot of the Division III athletes, but they're not at that same level as Division I athletes or professional athletes. So I don't have a lot of experience to say this is something that I see commonly with athletes as far as ulnar side of stuff. But I think anything, whether it's tennis, golf, baseball, any of those sports that require that, or fast pitch women's softball, things that require torque along the ulnar aspect of the wrist certainly could create problems. And then it's a matter of trying to figure out what that diagnosis is. And that's often the biggest challenge, is understanding what the diagnosis is. Because once you know the diagnosis, I think we have the treatments figured out, but sometimes the diagnosis can be elusive.
Great. Well, thank you, Warren. On behalf of the departments of orthopedics and plastic surgery in our hand divisions, your talks were fantastic, and we really appreciate you being here today. We will take about a 10-minute break. Everyone keep your link on because we'll stay on this link, and we'll start case presentations at 9 o'clock for about an hour or a little over an hour. For those interested in hand, residents applying for hand fellowship soon, please continue to join us for the case presentations with Dr. Hammert. So thank you, Warren. Again, an honor to host you at UVA. Hope to bring you here soon, and so we can go cycling together. Warren's a very avid road cyclist, and I'd love to have him down in Charlottesville at some point soon. So appreciate it very much. And everyone will reconvene on this same link, so don't close it down at 9 o'clock.
Now, thank you so much. It's been a great honor and a great privilege to be able to talk to you. And although I wish it was in person, hopefully at some point that will happen. But I appreciate the attention and the questions and the opportunity to visit you virtually.
Great. I know everyone needs to get to the OR for those of you who can't stay for case presentations. But fellows, Glenn and Lauren, if you can get ready to share your cases. I think we have maybe 4+ cases to talk and for you to share your thoughts, Warren. So thank you very much, and see you in a few minutes.
Sounds good. Thank you. All these sun things coming through my windows. I'm never here at this time of the day to know what it looks like, but I have a window facing the east where the sun is shining right in my face.
I thought it was your background that you were moving into, because there's, it's because I couldn't. You're right. The sun is shining in your face. I thought it was where you were moving back and forth into your background. So.
Yeah, no, I think it's just I'm never here at this time of the day. I guess I'm here on the weekends, but I'm not up in my office working. And
right. So how's the weather up there?
It's nice now. It was rainy the last week, but we've had days in the 80s. We've also had days that are still in the 30s or 40s, but it's the point where spring is certainly here and the ground is warm enough now that it's not. It's just kind of cool at night and early in the morning, then warms up during the day. So it's kind of the spring in Rochester, which is nice.
How's Debbie doing?
She's doing well. We've got a new puppy about 6 weeks ago, I guess. So that's occupying most of her time now, is trying to train and take care of the new puppy. Because she's in the world of dentistry, she must have gotten hit hard. My sister is a pediatric dentist. She shut down for 3-4 months and had to let go all her employees and so they could get unemployment benefits and then hire them back. I'm sure her work was affected too, right? She actually retired before everything hit. So she retired in 2019 and has just kind of been hanging out at home and stuff since then. So that didn't impact her from a professional standpoint. Personally, she's in the house all day normally, and then we couldn't get out anywhere at other times. So probably hurt her more psychologically than anything else. Right. Well, please say hello to her. It's been a while since we hung out. I guess the last Hand Society meeting that was in person. So, all right, we're going to go ahead and get started. And just before we start, Ray, I want to say you look very young. You've aged in reverse since you retired from UVA Health and retired from being a chair. So it gives me hope that I won't continue to get more and more gray. And but you look great. So it's great to see. It's been a long time.
You just need more time on the tractor and less time in the OR.
That's right. That's right. So
different stresses that happened at that point in time.
Yeah.
So Ray retired a little over a year ago, I think, maybe before COVID, right? So has it been 2 years, Ray?
No, it was just when COVID started.
Okay, got it. But you were chair of plastics for 28 years, 30 years?
29.
29 years. So that's unheard of nowadays and to last that long in a chair position. And either because of politics or either because you just get sick and tired of being a chair with all the craziness now, but very illustrious career here at UVA. So Warren, we have Glenn Lee is one of our fellows, and Lauren Fader. Glenn actually trained with Jonathan Isaacs in residency, so I actually broke all his bad habits along with the other UVA hand faculty and told him how to really take care of patients. But he's going back to join Jonathan on faculty after he finishes fellowship here. And Lauren Fader is our other fellow. She's from Louisville, and it's been a great year. She was a former Division I soccer player at Iowa State, so your conference, oh. And she's going back to Louisville as well once she finishes here. So they'll be presenting cases. We have plastics and ortho residents here who are interested in hand and will and as well as our physician's assistants. So looking forward to these presentations. So Glenn, do you want to start off?
Yeah. Let's share my screen. Oops. You all hear me?
Yep.
Thanks, Dr. Hammert, for being here with us today. Enjoyed both of your talks this morning. We have a few cases that are ulnar-sided pain related to discuss with you. I'll get started with the first one. So this is a 71-year-old male, right-hand dominant, who presented with chronic left wrist pain. He initially saw us in clinic 11 years ago and started receiving DREJ injections for arthritis. He has a past medical history of COPD, ulcerative colitis, and BPH. Significant surgical history. He has a total elbow on the side of the side that he's having wrist pain from a distal humerus non-union that led to post-traumatic arthritis. He ended up getting LRTIs on both sides and also has a total knee. No longer a smoker. So back in 2010, he presented with tenderness over his DRUJ. He had full motion, rotation of his forearm, no evidence of any DRUJ instability, and he was neurovascularly intact. Again, he received injections that with progressively worsening effectiveness, and he was wanting to discuss any surgical options for him. So these are his x-rays from 2009, around the time that he saw us, showing arthritis of his DRUJ. So Dr. Hammert, are there any more non-operative options that you would offer this patient, or would you offer him surgery? And what would be your next steps in terms of managing his symptoms?
So interesting patient here. In general, I find patients a lot of times will have DRUJ arthritis that's really not very symptomatic. And so for the number of patients with DRUJ arthritis that I see and compare them to the number I operate on, the number I operate on are very few. I think one of the things, kind of as we talked about a little bit, is you need to be as confident as possible that the symptoms are coming from DRUJ arthritis and not something else, chondrocalcinosis or something like that. Steroid injections certainly can be very helpful into the DRUJ, and if that's helpful, I certainly don't have a problem doing that for a while. I wouldn't do them every couple months, but if you can get by with 1 or 2 a year, maybe 3 a year, certainly a reasonable approach from a non-operative standpoint. One thing that I find kind of helpful for a lot of patients is the wrist widget. It's essentially a neoprene wrap that comes around the ulnar head and the DRUJ, and it doesn't, immobilizing someone and causing them not to rotate their forearm is different than a wrist splint. Wrist splints are tolerated pretty well, but doing something that blocks forearm rotation isn't tolerated very well. So if I'm truly confident that their pain is from the DRUJ, and it's really with forearm rotation more than flexion and extension or radial ulnar deviation, I think the steroid injections are the way to go. The plus to this patient is he has a total elbow. And so I assume that total elbow that was put in 2009 is still functioning. And that means he's a fairly low demand and is at least following the directions, because the elbow tends to be a limiting factor much more so than the DRUJ in someone that's had an arthroplasty.
Yes, and he's had no issues with his total elbow so far. So right in thinking that he's relatively low demand and compliant with his weight-bearing instructions. So ultimately, we ended up doing a DRJ hemiresection or Bowers procedure on him. And symptomatically, he did well for a long period of time. The x-rays from after the procedure to the right, and on the most right, you can notice that there is some evidence of DRJ instability, although it may be an element of x-ray rotation as well. But all in all, he felt well and was able to do his daily activities without much issue.
So in general, do you want me to comment?
Go ahead, please.
And so in general, I try to avoid taking out the ulnar head, because any procedure where we remove the ulnar head is going to result in some degree of radial ulnar convergence and impingement, and that's not always symptomatic. this is a patient where that I think is actually a reasonable idea just because they're a fairly low demand patient. And so someone that is a young, kind of going to be on the golf course, going to be lifting weights, going to doing things, I cringe when I think about taking out the ulnar hedge. But in this person, a Bowers type resection, what Kirk Watson has described as the match ulnar resection, I think is actually a pretty good operation. The ulnar variance is not positive, so you don't need to take the entire ulnar. You can preserve the TFC, which sometimes helps. The one thing that I've done with these is I try to, initially when the procedures were described, they talk about taking the palmaris and using the palmaris as an interposition in place of the ulnar head. I find that's pretty small in most patients, so I would use something bigger, an allograft, AKA what Dean Soterianos has described for the allograft interposition arthroplasty, I think is better because it kind of minimizes the chances of having symptomatic radial ulnar impingement with that. But I like the idea of a resection in this person just because he's going to be a lower demand person. He's got a total elbow.
Mm-hmm. So he did well for almost a decade, and then he returned last year in August with worsening pain in his wrist. On exam, he was very tender over his DRUJ and along his distal forearm. The DRUJ felt unstable and especially had pain with supination. And you can see on the x-rays on the right that he's developed radial ulnar impingement and arthrosis of the DRUJ. At this point, what would you offer this patient, Dr. Hammert?
I think if he's symptomatic enough for more surgery, this is one where I would kind of do what Dean has described. So the distal ulnar resection, a big allograft, Achilles allograft interposition between the radius and the ulna. And I think in this type of patient, they can actually do very well. I would be hesitant to want to do a DRUJ arthroplasty in this type of patient, given his elbow and his demand level. So with this, a resection arthroplasty and interposition, I think would be my choice.
Okay.
Dr. Hammert, in the initial case, do you, as a component of your practice, ever do implant-based arthroplasty for the DRUJ? If so, what are sort of indications for that?
Yeah, so in somebody that had, like the initial x-rays, if they didn't have the elbow, they were a, 50-year-old kind of worker, not necessarily a laborer, but a person who likes to play sports, play golf, play tennis. I think there's definitely a role. And so my kind of basic algorithm for that is if they have an ulnar minus or an ulnar positive variance, I like the partial ulnar head. The challenge right now is in the US, I think the only one that's available still is the Integra ulnar head. But if they don't have an ulnar positive variance, then I still like to try to preserve the TFC. There's one in Europe called the Eclipse that Mark Garcia Lyons has done a lot of work with. That's a pyrocarbon implant. And so there's probably some benefit to pyrocarbon over the other, because we know what happens when metal and bone articulate. The metal always wins. And I think that's the concept of pyrocarbon. And that's why Sanj has gone to putting a MCP implant in the ulnar head when he does these and using the calamari procedure. So using the allograft for interposition, because the pyrocarbon is more compatible with bone, but I don't have the guts to put a finger implant in that because I think it's probably hard to justify outside of the Mayo Clinic, and it's clearly an off-label use. So I've done a partial ulnar head for those. If they have an ulnar positive variance, if they've had a previous ulnar styloid fracture, then I do a total ulnar head replacement. I've used the Integra ones for those. I don't have any conflict with them. That's just the one that I'm the most familiar with and used. And I think a total DRUJ replacement is a really good operation in the right patient. I don't do it primarily, but for someone that's either had a partial ulnar head or a total ulnar head and it's not worked because the ulna has eroded into the sigmoid notch, or someone that's had a previous distal ulnar resection and is grossly unstable, then I think the semi-constrained linked prosthesis is a very good prosthesis.
Thanks.
So for this patient, he underwent a DERA after we evaluated him, stabilized the ulnar stump with a slip of the ECU tendon. However, soon afterwards, he presented for follow-up with inability to extend his ulnar 2 digits. And there was high concern for extensor tendon rupture. His x-rays show dorsally subluxed ulnar stump, and likely irritation from that had eroded through his tendons. So at this point, we went ahead and did what the original idea was to use the Achilles allograft. So he had an Achilles interpositional graft placed. The interosseous membrane was stabilized with a tightrope as well, and then he underwent EIP to EDC to the ring and small transfer to restore his tendon or his extension to those fingers.
Yeah, that's a great case, a tough problem. I think when I do a distal ulnar resection, I try to stabilize that as much as I can. And so I'll bring the pronator quadratus up and suture it dorsally into the distal ulna. I'll often use both the ECU and the FCU stabilization that Jesse Jupiter and Breen described several years ago. I think all of those, whether you go back to some of Bill Kleiman's early ones with the ECU, the FCU, or the combined ones, those are all okay for minimizing dorsal volar instability in neutral position, but as soon as you pronate or supinate the forearm, it becomes less stable and you get some degree of convergence and you get some degree of dorsal volar translation of the radius on the ulna. And that's always kind of the concern is, are you going to erode through the tendons and rupture them? So as good of a soft tissue reconstruction as you can at your primary procedure, immobilizing them for about 6 weeks, has been reasonably successful in my hands, but it's always a concern back in the back of your mind just because of the potential for the ulna rubbing into the tendons and causing an attritional rupture. But I would do the same tendon transfers that you described there for them. EIP, I'll bring it over. Often I'll bring the EIP to the small finger and do the EDC of the ring finger to the middle finger, but I think using a side-to-side and a EIP transfer in some manner is a good approach for the tendon reconstruction.
So he presented for follow-up about 3 months later. He complained.
This is the case. This is the gift that keeps giving, right?
Yeah,
Case. Every procedure you can do has been done on this.
Yeah, he had progressively worsening prominence of his ulnar stump. Became very prominent with pronation, and he was actively able to extend his digits, but it did cause discomfort. We were worried that it may lead to further extensor tendon irritation and issues with that. So Dr. Hammert, what would you, how would you manage this patient at this point? Would you continue to watch it, or would you offer him another intervention?
I think there are a couple of options at this point. And it's obviously concerning that he still has kind of a grossly unstable stump. Overall, this is where I would consider putting a total DRUJ prosthesis. So I like the one that Louis Schecker has described. We have a bit of a challenge because we have the implants in the radius, and that's where the radial plate is going to fit. And so that's going to make it probably challenging to do, but I still may consider that. With the holes in the radius, you certainly have a risk of a stress riser and creating a fracture in the radius somewhere down the line. So I'm leery of that, but that would be one option. The other option is to continue resecting the ulna further proximally. And so I guess two more options. One option is to consider resecting the ulna further proximally. There's not a lot of good data about that, but there's a paper that Scott Wolf published about 20 years ago, and it was somewhat of a heterogeneous group. Some patients were tumor patients, some were trauma patients, but the thought is eventually if you resect enough of the ulna, they will have less instability, they won't have anything to irritate the tendons and have a problem. I've never done that, right? I guess I've done that once on a patient and I'm not sure I made him better, but he went away eventually. And nobody, our community is small enough, probably similar to yours. It's not like New York City where there's 50 other surgeons around the block that they can go see. So generally, once you've operated on someone in Rochester, New York, you kind of own those patients. The other operation, which I think is a problem and certainly could be considered with this, but I think is a very big operation, is a one bone forearm. you look at the outcomes of that, and people function pretty well with a wrist arthrodesis. They can do most things they need to do. And I think the forearm is kind of the forgotten joint. But if you take away pronation and supination, that's pretty debilitating for most patients. You look at the outcomes of that, if you can get it to heal, they tend to be okay. But I think it's because they're so miserable when they start. Sometimes they're happy having things done. There was a good case series from the Philly Hand Center published in the Journal of Hand Surgery. I lose track of time, probably 10 years ago or so, where they looked at those patients and they had improvements, but they were still pretty miserable overall as far as their levels of function and their level of satisfaction with the procedure. But I think by the time you've gotten to that, they've gone through multiple procedures like this. So I think of the options that you have here, I would probably be leaning towards a further proximal resection just because I'm a little bit leery about trying to do the DRUJ implant in this patient. But I think it's a discussion with the patient of these are your kind of 3 options, none of which are perfect and all of which have risks of needing additional procedures.
Got it. So we ended up doing putting in a Schecker prosthesis. Unfortunately, our fluoro shots didn't get saved, but for anyone in the audience not familiar with it, there's a picture of the prosthesis and the X-ray I found on the internet. We were able to remove one of the anchors that was prominent to get our plate down on the ulnar side of the radius. And we used one of the longer ones that would span that region to try to minimize risk of fracture through previous holes. Yeah, his first follow-up's actually today, so we'll see how he ends up doing. And one of the things I kind of noticed about this prosthesis, and like you mentioned earlier, Dr. Hammert, with prosupination, your ulnar variance changes, the ulnar head translates in a radius ulnar direction. So what are your thoughts on having this much constraint at the DRUJ when the normal motion is for it to translate dorsally and also to be relatively more positive compared to the radius?
So I think actually this is a very good implant. I think the complication or the need for revision procedures with this implant is fairly high. And if you look at some of the series, particularly Doug Hanel has one in his group of patients in Seattle, it's about 25 to 30%. So I think that's kind of one of the keys is letting the patients know that many of these people have symptoms and need something done down the line. Most other, if you looked at a hip or knee and you said, okay, we've got a 25% revision rate, we're going to consider this success, they would look at you and say, you're nuts. This is an awful procedure. But the problem is we don't have a better operation for it. This implant is unique in that it does allow some proximal and distal movement of the implant, but as you say, it eliminates that dorsal volar translation. So far, it seems to work really well. I've been doing this for a while. The data that you look at, a lot of it is by Louis Schecker and his group. And so I trust Louis Schecker. I think he's honest, but he's clearly conflicted because this is his implant. But if you look at some of the series of complications and revisions, I tell patients 1 in 3 to 1 in 4 are going to need to have something done with this down the line. I think your x-rays look really good. Couple of the tips that I think are important with this, there's almost always a volar lip of the radius. And when you're putting this in, that radial plate has to sit flush or it's going to be torqued and it's eventually going to loosen. So I always take a saw and cut that volar ulnar margin of the radius at the sigmoid notch to make sure that that's as flat as possible. And then getting your trials in. It is nice because you can create the different length of a stem. And so almost regardless of how much of that ulna has been removed, they can get you an extended 4-centimeter collar, which will cover almost any previous resection. So I think this is a good implant. I'm worried a little bit just based on the previous hardware that was there, if that you'll have a stress riser. So normally when I do this, I put them in a removable brace at a week. Someone where I've kind of worked on the radius like this, I would probably immobilize for several weeks before I let them start moving in an unrestricted manner. But I think the ones that I've done, I've had really good kind of outcomes with them. And I've probably done 8 or 9 over the years, maybe 10. So not a huge number, but I think in the right situation, this is a really good implant.
And the stem that we put in was like adjacent to the cement mantle from his total elbow too. So that worked out. And we were able to avoid interfering with that.
Yeah, something that you have to think about with most. And these patients, even though, the way that they test these implants and determine what you can do, I always think that most of my DRUJ and ulnar head implants patients do a lot more than I would like them to do. I tell them, this is what you should do, but, patients, when they're feeling good, generally get back to doing heavier things. But I think the elbow is going to help you in this situation. The fact that he's had an elbow in for, 11 years, 12 years, means he's at least somewhat compliant and hopefully not going to overdo this. But I have patients, once I put this in, that are back playing golf, playing tennis. They're doing, not super heavy powerlifting, but certainly activities that you get a little bit leery about with any sort of an implant around the hand or wrist, and have done pretty well.
Great. Well, thank you so much for your comments on this case. Any comments from the audience before we move on to the next one?
So this is my
Yeah.
patient. We got to the end of the road, and Shecker was kind of the move. Going back to like the progression through, we started with the Bowers on purpose because I didn't presume he had longitudinal instability, but he'd had the total elbow, and I wanted to kind of watch that. The DARA, we felt like it wasn't super stable. We tried to stabilize it. I could tell it was more mobile than I would have suspected. But at the time, it was kind of let's watch and see. And then reconstruction, we did everything. We threw the kitchen sink at that thing. And all this stuff was still in play, but the ulnar was just so mobile. And it's almost like since he doesn't have a lateral column, the radial head, the radius just kind of tilts.
Yeah.
And he likes to be in pronation. That's kind of a position where most people kind of like to be, especially if you're typing and everything else. And so even though we held them in supination and held them in neutral for a long time, it just wasn't stable. Shecker they're pretty awesome from the standpoint of they won't do the surgery unless they feel it's going to work. So I had to send forearm films. I had to send measurements. They sent me a pretty outlined detail as to what the implant should look like, the measurements, what they presume would be the right implants. Their engineers in particular were very involved from kind of the beginning to the end. The case went as advertised. Felt pretty good. I mean, there was the submitment on the ulna, but we were short enough to where we felt like it was good. I'm still concerned about his stress riders there, obviously, but his activity is somewhat limited due to the total elbow. So I'm not that worried about a fracture. Obviously, it could still happen. We could have bridged it with a plate, but I'm not trying to put any more metal in him than needed. But it's probably the first time I felt really good about his forearm rotation since he had his first surgery. So to that end, we'll see. He's actually coming today at 10 o'clock. So more to come on that. But usually he calls or sends a picture if something bad's going on. So knock on wood, hopefully things seem to be doing all right. Their recommendations on immobilization are more in line with starting forearm rotation more quickly. Long arm kind of like Munster type casting is what I was thinking, but they're more in kind of short arm casts, let them start forearm rotation so it doesn't get tight. I don't know what the right answer is for that. I'm more inclined to be more conservative and at least for a few weeks before letting him start to rotate, but I'll see when he comes in.
Yeah, I think that's a great job on this. It's a tough case. I do think there's Brian Babb is the guy at the Shecker company that I've worked with at Aptus, and he's phenomenal. You send them an X-ray, you kind of put a quarter on it so they can template the size, and will give you very good detailed information. So I agree, they're not letting this be put in just anybody. They want to make sure that they think it's at least a reasonable candidate for their implant, because they obviously don't want their implants to fail, and these are expensive implants. And yeah, generally I will move them at a week, but in someone like this that I'm a little bit cautious, I would err on the side of going a little bit slow. I think even if he's a little bit stiff and he doesn't have another problem, that's a victory, as opposed to having great movement and then end up kind of a screw loosening or starting to back out, or even worse, having a fracture you're trying to plate around that radial implant, which would be very difficult. But great case, great challenge, but hopefully you've helped him out, and hopefully this is his last operation he needs.
I hope so. He's a nice guy, and I hope so. So
Yeah, if he was a jerk, it would have worked the first time.
yeah.
It would have worked, but he would have still been unhappy.
Yes.
All right, next case. Great presentation.
The next case is a very interesting ulnar fracture that we dealt with. So this is a 23-year-old male. He basically woke up the day after Christmas after getting drunk with his brothers and roughhousing with them, and with severe left wrist pain. He doesn't remember exactly what happened. He noted that he has noticed decreased rotation of his forearm. History, pretty insignificant, except that he's using nicotine gum. On exam, he had tenderness over his DRUJ, very significant pain with prosupination. His range of motion was limited to only about 20 degrees of pronation, 45 degrees of supination. His DRUJ felt stable. So here are his x-rays that were taken at an urgent care center before he presented to us a few days after his injury. You'll notice he has like a shearing of his ulnar head and some impaction related to it. Dr. Hammert, would you obtain any advanced imaging for him or proceed with a treatment plan?
Yeah, no, this is an unusual situation. And I guess if he's intoxicated, maybe you don't buy the story if he just fell, but it's certainly an unusual injury pattern here. I definitely would want a CT scan and maybe an MRI even as well to try to better understand.
Warren, do we lose you here?
Can you hear me?
Yes. Yeah.
Okay. I didn't know
All
if I disappeared there. So yeah, so an MRI, a CT scan and MRI, I think would be what I would be interested in at this point in making a decision as far as how to treat it.
Okay. So we did obtain a CT scan. Here's some selected axial cuts. There's an incongruity at the level of his DRUJ and the ulnar head.
You have sagittal cuts? Okay, these are helpful. Let's see the coronal.
Some coronals. And then here are some selected sagittals. So there's a reasonable degree of combination as well. So Dr. Hammer, how do you think you would treat this patient? Would you cast him or offer him surgery?
So how unstable is his DRUJ?
His DRUJ is stable, but his motion is very limited.
Can you go back and let me see the initial x-rays again?
Sure.
So I think you probably have something interposed there. So I think just immobilizing this, although I'm not sure how much better the surgery is going to make it, at least clears that piece out of the sigmoid notch.
Mm-hmm.
And you've got a little better sense of what it looks like. I don't know how easy it's going to be to repair that piece. And so I would probably approach this dorsally through the fifth extensor compartment, expose that, get whatever that piece is out so the sigmoid notch aligns as well as possible, and see what is there as far as cartilage on the sigmoid notch, and probably with the idea of some small screws to try to hold that piece in place, assuming that it looks feasible with that. Maybe K-wires, maybe even some suture with some drill holes through the ulnar aspect of the ulna, just to try to suspend and hold that kind of articular surface aligned as well as I can at the sigmoid notch. So I think part of it would depend on what I see, but I think non-operatively, it's just going to heal and it's going to be a mess and you're never going to get them to move. So I think I would at least look at the joint, try to get any kind of small pieces out of the joint, wash it out, and try to stabilize it as well as I could.
And that's exactly the discussion we had with this patient. We said we'd go in and take a look at it. You know, if it was very highly comminuted, we would consider taking out the pieces, or if there's something that we can fix, that we'll fix it. And our method would depend on what we saw in the OR. So we ended up actually taking a volar approach, just because from the CT scans, we thought that most of the pathology was on the volar side and might have been easier to visualize and get to. Made a capsulotomy in the DRUJ, just proximal to the TFCC. There was one large kind of radial volar fragment that we were able to fix with a headless compression screw. And then there were some smaller fragments that we use these arthritic chondral darts that I guess sports people like to use in knees and stuff. It was the first time I used the product, but we were able to secure some of the smaller, more comminuted fragments back down as well. And after we did this, his passive prosupination motion was restored pretty much back to normal on the OR table, and then we mobilized them in a sugar tongue.
I think that looks really good there. I think just by the nature of the injury, he's probably going to have some trouble, or is at least going to have radiographic arthritis. Hopefully it's not symptomatic and you don't have to do anything. But as a 21, 23-year-old or whatever he is, I think the key is, or the good thing is, you're going to be moving back to Richmond soon and you won't have to deal with this when he comes back in a few years with another problem. But I don't think the story is over, but I think it looks really good right there.
So this was post-update 10 when he followed up in clinic. We transitioned him to a Munster cast, and then 2 weeks after that, we're going to get him into a brace, and we got him into a brace and started exercises. There was some concern about maybe some osteolysis around the head of the compression screw, but we'll just continue to see what happens and see how he does. So.
Yeah, tough problem. That looks really good there, but just the nature of the injury with time, I think that's going to be his enemy.
Yeah. Cool. Thank you so much. Any other comments from anyone else?
And this is mine. Thanks for your input on it. I've never seen this injury before. It was an odd injury, and in a young guy, and it presented, of course, late, which made it extra challenging. So by the time he got to see urgent care and then see us, this was already starting to heal, and this sort of weird marginal impaction fracture. But I've never seen an injury like that that isolated to the DRUJ. I thought that was kind of interesting. But in terms of the approach, I don't know whether we would have been able to see it easier dorsally or not. Most of it was volarly, but it was still really challenging in a deep hole to try to get that fixed. And essentially this shear fragment was just kind of impacted down, and once we elevated it up and made it look anatomic, there was a big void underneath it that we tried to pack with some graft, and luckily there was a big enough piece that we fit the screw in. Hopefully that'll help. Those chondral darts were interesting. I don't use them very often, but short of a piece that's big enough to put a screw in, I don't know what else there is other than suture, like you mentioned. I think that was a good idea, but that was kind of the plan, is to just put something in there or excise it. I think the one thing I'm curious to see what you would say about this is, if he had not been locked, so I think we were sort of forced to do something because he's a young guy and he essentially had locked rotation, and just leaving him like that, he wasn't going to gain any motion, I don't think. But if he had normal rotation on presentation, would you have just sort of left it alone and just seen how it was at that point, given he was 3 or 4 weeks out from his injury? Or would you still try to go in there and fix it anatomically or excise a fragment?
Yeah, I think that's a good question. And hindsight is always 20/20. I think if he could fully rotate the forearm, even if he was having pain, I would probably have just left it alone. I think the fact that he couldn't is what pushed you, and you look at it and you say, there's got to be a piece in the sigmoid knot that's blocking him. So there's got to be a mechanical block. But if he could fully rotate the forearm, I'm not sure I was going to make him better by surgery. I could make him different, but I don't know if he'd be any better. And in that situation, I would have probably, at several weeks, just immobilized him for comfort and then got him moving.
Thank you.
All right, I'm gonna show a couple cases now. Thank you, Dr. Hammert, for being here. Again, my name's Lauren. The other fellow got a couple of interesting cases to show as well. So this is AN. He's a 16-year-old right-hand dominant male who presented complaining with right wrist pain and instability. He reports that he injured his wrist about 6 months ago. He thinks it happened when he was kind of messing around boxing with a friend. Didn't initially seek treatment at that time, but has had persistent pain, mostly with activity, things like playing basketball. As far as location of the pain, he says sometimes it's radial, sometimes it's ulnar. He doesn't describe any numbness or tingling. Pertinent findings on his exam, he did have a slight mid-carpal sag. He was non-tender at his SL and LT intervals. He had a negative LT shear test, but he did have this painful clunk with a Watson's maneuver, and his DRUJ was stable. So these are his initial x-rays. Let's see, he's skeletally immature. AP views and a clenched fist view here on the right don't really show anything super significant. The SL interval appears normal. Didn't appreciate any LT widening, but you can see on this sagittal view here in the middle, he has a bit of a VZ deformity. And then there's also this vulsion fragment, which appeared to come off of the volar lip of the lunate here. So kind of an interesting fracture and presentation on the x-rays. So just kind of like to get your initial thoughts on that.
Yeah, interesting case. When I think of kind of a VZ, I think of more isolated lunate flexion and something disrupted. This looks to me like almost the whole proximal row is flexed. The scapholunate angle doesn't look bad. I think they're just both, the scaphoid is flexed, but so is the lunate. And so kind of, this makes me think of more of a mid-carpal instability pattern as opposed to something when you think of a VZ as a lunar triquetral type of injury pattern. And the fact that he's not tender in, over the lunar triquetral or the scapholunate interval would also kind of lead me to think about a mid-carpal problem. This is a situation where if you have access to fluoroscopy, you can often get a lot of benefit. So putting them under the fluoroscopy, moving them from radial to ulnar deviation will often enable you to see kind of where the clunk is and what they're feeling or what you're feeling on that scaphoid shift maneuver. The other thing on exam that I find is very helpful in evaluating these is I stabilize the DRUJ and stabilize the carpus to the radiocarpal joint by putting dorsal pressure on the pisiform and volar pressure on the ulna. So as I'm doing it, I will do that and then move back and forth and see if I can eliminate that clunk. And so volar pressure on the ulna with your fingers, dorsal pressure on the pisiform will stabilize that. And most of the times with mid-carpal instability, that will eliminate that clunking sensation that they feel. And if that's the case, I'll have the therapist create what we call a piezotriquetral boost splint to try to keep that, to eliminate that sag and to keep the proximal row kind of extended or at least normal as opposed to flexed like you see here. Because when they clunk, it's usually as they go into ulnar deviation, the whole proximal row extends and you get that clunk with the capitate sliding more dorsally.
Mm-hmm.
If that makes sense. Hopefully you understand what I'm trying to explain here.
Yeah, no, that makes sense. And that's a good thought to think about, dynamic fluoroscopy in the office. We did get x-rays of his left wrist just for comparison's sake to make sure that he didn't have, any kind of similar findings on the other side, and felt that those were relatively normal. Would you think about getting any advanced imaging at this point?
I would probably get an MRI just because patients kind of like things. I'm not sure it's going to add a whole lot. I don't anticipate looking at the MRI and being able to say, this is what the problem is, but it does sometimes give you subtle clues as to something else that's going on. But I think based on what you've described on the exam and what I'm seeing on the images, I think this is a problem at the mid-carpal joint, which I think is, in this situation, easier to diagnose and for me harder to treat because I don't have a great treatment for it. But I think his problem is a mid-carpal instability pattern. I would probably get the MRI just to see is there something else that I haven't appreciated that's there.
Sure. Yeah, and we did get an MRI. Unfortunately, the images weren't in our system, but kind of like you said, it wasn't really that informative. It didn't diagnose anything specific. We could still see the flexion of the lunate, but no obvious ligament tears or anything like that. So, you know, well, before I get that far, as you mentioned, kind of some mid-carpal instability. He obviously has that avulsion fracture, which looked like a decently sized fragment. So just as far as treatment options, what are your thoughts at this point? Would you consider arthroscopy, open approach? How would you address that fragment and those kinds of things?
So the MRI hopefully is helpful as far as showing me the fragment. When I think of this, and you know, I use the term mid-carpal instability, I think if you look at a lot of the people that, you know, the international wrist investigators, they've kind of redefined this to the term proximal row instability. And so the proximal row is kind of that intercalated segment. But that being along the volar side is a little bit unusual. I typically think of maybe something as far as the dorsal radiocarpal or dorsal intercarpal ligament being avulsed from the triquetrum as opposed to something along the volar side that's avulsed. So I'm hopeful that the MRI gives me some sort of a sense of, you know, where the change is on the lunate or where this is coming from. I've never seen or treated this type of thing. I think my approach would be initially to try to splint the patient and see if that piezotriquetral boost splint and some eccentric strengthening of the ECU and the FCU help stabilize and eliminate that instability pattern. If that hasn't worked, I'm probably going to start with a scope, but I don't think I can perform definitive treatment through a scope. And so then probably going to need to open it up. And in the handful of these that I've done soft tissue procedures on, I've always gone dorsally. I think with what I see here, I've got to figure out some way to go to the volar side, but I'm not sure I've got a clear answer as to exactly what is there and how I'm going to repair that on the volar side. But if it's avulsed off and that's what's responsible for the proximal row flexion, I think if we can reattach that and kind of reef the volar ulnar carpal ligaments, hopefully that would stabilize things that enough that the proximal row becomes stable and doesn't flex.
Great. So our plan, as you said, was to start with a wrist arthroscopy, and then kind of based on what we saw within the joint, we did plan to likely open it and kind of address the ligaments and possibly that avulsion fracture based on the character of the fracture once we got a good look at it. So just showing some arthroscopic images, once we got into the radiocarpal joint, looked very healthy. You can see the radial styloid, and then the volar ligaments are intact. And then on the right here showing the SL interval, the SL ligament, which is intact. Looking more ulnarly at the TFCC, that was also intact, no signs of a tear or instability. Here, centrally looking at this was at the LT ligament, it did appear to have kind of this frayed appearance, a little bit of a flap, which we got under with the probe. So suggestive of some LT disruption possibly there. So then we moved to the mid-carpal joint, and on the left here, this is assessing the SL interval, which appeared stable. When we did probe the LT interval, there was some instability there. You can see we were able to get the probe in there and turn it. And then on the right here, this is demonstrating, this is the volar lip of the lunate, and this here is that avulsion fragment. So it was a pretty large fragment, and we were able to get the probe kind of in the fracture site, and that fragment was fairly mobile. So our decision at this point was to open volarly and try to reduce and fix that volar fragment, and then hopefully restore stability to that mid-carpal joint. So once we did open it volarly and approached the volar capsule, where we opened it, kind of made an L capsular flap, and we're able to visualize the fragment there. Prior to opening it though, sorry, I got ahead of myself. We did reduce the lunate. So we extended the wrist to take it out of that proximal carpal row out of flexion, and pinned the lunate to reduce it. And then that allowed us to have our alignment of the capitate on the lunate restored. And we then pinned percutaneously across the lunar triquetral joint, and then another pin from the triquetrum into the capitate as well. And then we did open it volarly and address that fragment. And once we were able to visualize it, we kind of curated out the fracture site and used two Arthrex nano corkscrew anchors and put those into the lunate. And then we were able to sort of lasso that fragment back down and suture it down into place, and felt like we got a pretty good reduction there, as you can see on the sagittal view. So and then we closed it back up and immobilized him. So just kind of curious of what your thoughts are on that approach.
That looks great. This is a really cool case. We know that the lunar triquetral ligament is strongest along the volar aspect, but by and large, we kind of ignore that. You think about, perilunate dislocations will generally repair the dorsal, at least I'll generally repair the dorsal portion of the LT ligament and just rely on scarring along the volar aspect. And here, a little bit harder to do. The dorsal wrist exposure is pretty good and you can see everything very well. It's hard to see stuff from the volar side. You're opening, you do an extended carpal tunnel release, you're retracting things, you're kind of making transverse cuts in the capsule to try to see things, and the visualization from the volar side is much harder. So I'm impressed with the way that you're able to get that back together, because that looks really great. I think, as you said, one of the things I find very helpful for, whether it's radial-sided or ulnar-sided problems is pinning the lunate to the radius in neutral. And that helps with your alignment. And I don't always leave them in, I'll usually take them out. But while I'm doing an SL reconstruction or doing a scaphoid non-union reconstruction, just to get the alignment of the carpus, I think pinning the radial lunate joint is helpful. And you're a little bit more leery when someone has open growth plates, but still in a situation like this, where it's probably close to closing, I think a good way to maintain the alignment while you're fixing things. And that gives you a sense of where those fragments should be along the volar side, because you're looking at that and I at least have no idea kind of where the carpus is when I'm trying to look through the volar capsule to see that. So I think that looks really good. I would probably lock him up and leave him there for a while, give him 6 weeks or so of immobilization, and then try to get him moving. But I think he's actually going to do really well based on what I see here.
Yeah, so that's exactly what we did. He's immobilized in a splint and then transitioned to a cast for 6 weeks. And the most recent x-rays we have are shown here. This was a few weeks ago, and the pins were just pulled last week or so. So hopefully kind of get him start moving now and start rehabbing. But so far, things look pretty good. So
it's a really cool case.
And then another one of the weird ones that I'd never seen this either before. And honestly, I think I probably misdiagnosed it going in, although we sort of had the kind of kitchen sink plan, had a general idea of where the problem was. But I thought initially that we were going to find that the LT was sort of attached to that piece volarly, and it was some sort of LT pattern instability. Once we got in there, it was clear that it was a more mid-carpal problem. So I think you're spot on. And I think the points that you made, especially about diagnosis in terms of that physical exam maneuver and especially fluoroscopy. I think if we'd done some dynamic fluoroscopy, that also probably would have helped in terms of making the diagnosis. But ultimately, I was happy with how it went. Again, in a sort of deep hole, and we're able to reduce that. So we'll see how he does. Hopefully we win, given that he's 16.
Yeah, I think that looks really good. I would be excited about where you are right now, because I think he's got a very good chance of doing well.
Great. All right, and I can move on to another case here. This is GP. He's a 36-year-old right-hand dominant male who presented for evaluation of right wrist injury that he sustained in a car accident that had happened 6 weeks prior to his presentation here. He was initially seen at an outside facility, I think in urgent care, where they did x-rays and, you know, kind of felt something wasn't right. So they put him into a splint or cast and kind of sent him on his way. Past medical history wise, he is significant. He's very obese. But he is a non-smoker, and he works in this works as a plastics processing technician, so kind of an industrial type of job. On exam of his wrist, when he did present to us, he was in a cast, so he initially weren't able to get a great exam, but his fingers were a little bit stiff just from being immobilized, but he did have intact 2-point discrimination, but he did complain of a little bit of subjective numbness in his thumb and index finger. So these are the x-rays from the outside facility when he initially presented there. And kind of interesting, a couple things that to point out, we don't have a great lateral view, but on this image on the left, you can see it looks like there may be a triquetral fracture with a fragment kind of displaced dorsally, possibly a little bit of a DZ deformity here on this view. The lunate appears to be slightly extended. And then on this AP view, the SL interval doesn't look quite right. And then you can see Galula's lines are clearly disrupted here. The hamate, the capitohamate junction here is definitely not normal, suggesting that the hamate is subluxed or dislocated somehow. So kind of like to get your thoughts on these x-rays.
Yeah, this is like a lot of the ones that I see. You kind of have 3 pseudo oblique views, but you don't have a really good PA view. You don't have a really good lateral view. And so I think my starting point is trying to get better images to understand kind of exactly what's going on. But clearly the 4th and 5th CMC joints don't look right because of the hamate. That's presumably the hook of the hamate that is positioned or angled out towards the 4th metacarpal as opposed to directly volarly. Maybe overlap, but a little bit of irregularity in the proximal aspect of the hamate. I don't know if I've ever seen an isolated, I guess I know I have not ever seen an isolated hamate dislocation, but this almost looks like it could be that with a fracture associated with it. Another thing that you notice when you look at the lunate, you can see the volar rim more prominent than the dorsal rim. And so that goes along with what you described as extension of the lunate there, because the dorsal and volar rim should be fairly in line with each other. And so I think I would want better plain images to start off with, but I'm ultimately going to end up with probably a CT scan to evaluate this and see what's going on. We've got a cone beam CT scan that we use. And so I don't know if you're familiar with that or have that there, but that's a very kind of low radiation CT scanner that is specific for distal extremities. So predominantly hand and wrist and foot and ankle. And the amount of radiation that you get with that is about the same as 4 plain x-rays, so much less than a traditional CT scan. And that's something that it's provided really good images and has been very helpful with that. And I often don't get 3D reconstructions, but I think it'd probably be cool to see a 3D reconstruction of this CT scan to really understand what's going on there.
Sure. So we did get a CT scan. And I felt like this axial view was kind of the most informative. As we scroll through here, you can see that here's demonstrating a triquetral fracture. And then as we move distally, you can see here's the hamate that appears to be displaced volarly. And then the 4th and 5th CMC joints kind of went with it volarly as well. So kind of an interesting fracture pattern. And just
what was his initial injury? This is more of an axiocarpal dislocation, which is generally a very high energy injury now that I see this. What did happen to him initially?
He was in a car accident.
Okay.
Yeah. No other major injuries, but yeah, I agree. Definitely appears to be a high energy mechanism. And again, has just kind of been immobilized in a cast for the past 6 weeks. So kind of thinking about that it's, not a fresh injury, but clearly needs to be addressed. Curious what you initially would think about doing for him.
Well, a bit of a challenge here. And then the fact that he's got a BMI of 50 plus makes it also a challenge. I thought those patients were all in upstate New York. I didn't realize they had those in Virginia, but apparently there's at least one. Yeah, so this, I'm thinking, my mind is this is kind of more of an axial carpal type of dislocation. And at this point in time, it's going to be hard to get it back into, alignment, but I think you're going to need an open approach. You're going to have a bunch of scar that's along the volar aspect of where that hamate is. And obviously the concern is the ulnar nerve and ulnar artery kind of right deep to that. But I still think I would go in dorsally with this kind of a longitudinal exposure. Get the triquetrum into as reasonable position as possible, and you're probably just going to pin that, but then try to get the hamate reduced, which should restore the alignment of the 4th and 5th CMC joint. And the hamate is, the capitohamate joint is generally a stable joint. Depending on what the cartilage looks like, I may put just a little cancellous graft in and put some pins just to try to get that to fuse, because we're 6 weeks out and the ligaments healing are not going to really be helpful, and you're going to have to mobilize them for a while. So I think that's my at least initial thought based on what I've seen. Dorsal approach, get the hamate reduced, maybe some cancellous graft in the capitohamate joint, and then some pins or potentially temporary screws.
Great. So go ahead here. So we actually plan to do both a volar and a dorsal approach. I think the thought with going volar was he was having some subjective numbness and tingling, and so we felt like releasing the carpal tunnel was made sense. And then also we thought that potentially going volarly might assist us in reducing the hamate, depending on how difficult it was, because it was kind of volarly displaced, that maybe if we could push from the volar side, that might help us. So, so we started volarly, did an extended carpal tunnel release, and kind of, retracted the median nerve and the flexor tendons to get a look at the volar capsule. We didn't open anything deep volarly, but we're able to kind of palpate the hook of the hamate. And then we opened him up dorsally, did a ligament sparing capsulotomy. And the freer here is in that capitohamate interval. And you can see this is the hamate here, and it's displaced volarly. And it was really difficult to actually get that to reduce. As you mentioned, it had, obviously 6 weeks out, it already started to scar in, and things had kind of contracted down, but we were able to use the freer to kind of lever up on that and reduce the hamate and the 4th and 5th CMC joints as well. And then this image is demonstrating we're in the SL interval here, which was clearly disrupted as well and unstable. And so another aspect that we needed to address. So basically our approach, we did, once we opened it, we kind of reduced that hamate back, as you mentioned, and we did basically formally fused the capitohamate joint, because we just cleared out any remaining cartilage, packed in some cancellous chips, and then actually put a headless screw across it, as well as a second percutaneous pin to get that to fuse. And then we fused the base of the 4th and the 5th over to the 3rd, or we pinned it there just to keep it stable temporarily. And then in the proximal row, we put a tenaculum clamp across the scaphoid and the lunate to close down the SL interval. Once we had that reduced well, we placed a pin across it, and then put a pin from the scaphoid into the capitate as well. And then did a SL reconstruction using a couple of suture anchors there. And then we did a capsulodesis, that's what this is attempting to demonstrate as well, kind of on our way out, using the flap of our capsulotomy. So these were our post-op films, and felt like we got a pretty good reduction there, but it was definitely a tough case trying to get everything lined back up.
Yeah, that looks really, really good there. Did you use a graft for the SL reconstruction, or did you find enough native ligament that just use that in the dorsal capsule, or
yeah,
what did you use for that?
We didn't use a graft. We just kind of had enough native tissue, and then again used a flap of the capsule to secure that down.
Yeah. I think that looks really good there. The only other thing that I might have done, if I was going to go volar, I probably would have explored the ulnar nerve and released that through Guillen's canal, particularly the motor branch around what theoretically was the hook of the hamate, just because as you push that hamate back into position, you always worry about, is that going to push on the ulnar motor nerve? And he's going to be pretty swollen afterwards. So I would probably have thought about adding that just for peace of mind, so I sleep better when he comes back to the office and he says he's, weak, his intrinsics are weak or something like that. But I think that looks really good overall. Kurt, certainly consider your starting point. I think you've done an excellent job there.
Great. And then just a little bit of his follow-up. This was his initial post-op appointment. Everything was kind of maintained, alignment. This was his most recent x-rays back in January. I believe he's going to be following up somewhere closer to home, but these are the most recent x-rays. But it looks like the capitohamate joint has fused and things are kind of where they need to be still. So hopefully he will continue to do well. He has gone back to work and things like that. So
it's a victory considering your starting point. That looks really good.
Thank you.
I think that's our last case presentation. Is that correct, guys?
Yes.
All right. Any questions? Because I know people have clinical duties to get to, and over 3 hours on a Zoom education meeting is not easy. But any further questions for Dr. Hammert on this topic or any other topics?
Those are great cases, great challenge, but certainly things that you like to see as a fellow or as a resident rather than the first time in practice, to have somebody to bounce the ideas off of. So thank you for the presentations and the discussion. Very interesting, and I enjoyed it.
Yeah, some very unusual cases. So, and believe me, once I get you down here, there's some really nice Southern fried cooking here. So we got plenty of high BMI patients in this region. So,
okay.
But we'll get you here soon. But thank you again, Warren, for joining us this morning and being part of our yearly or annual Morgan McHugh Visiting Professorship in Hand Surgery. Great turnout. We had almost 85 people for your morning lectures this morning, and then a large number of our residents who are interested in hand surgery and our fellows for this case presentation series. So I hope I sent you a bottle of the best wine from down in this region. Charlottesville has about 80 vineyards in about 30-40 miles of in radius. So I hope you receive that along with the other things we sent you to thank you for spending time this morning. But looking forward to seeing you very soon.
Yes, thank you so much, and I'm truly honored and humbled that I was invited to participate in this, and so I've really enjoyed it, and I appreciate the kind gifts and the gestures that you had sent. So thank you so much.
Warren,
Dr. Morgan.
I just wanted to discuss some small world topics. Jim Zins, who's Cleveland Clinic, and Lou Lane, who's a hand surgeon in Long Island. We were all high school classmates together.
Oh my gosh, small world.
We all graduated together in the same year,
I know both of them very well. I haven't seen Jim in a while, and I haven't seen Lou since we've hadn't had an in-person meeting in a while, but that's funny, small world.
And I visited Oklahoma a lot of times, both Stillwater and Oklahoma City, because Russell Postier, who was the chairman of surgery, was at Hopkins as a resident with me together as well.
Okay. Yeah, I always said Oklahoma's a great place to live, not a great place to visit, but it's a relatively safe place and a good place. So that's very interesting. Thank you for sharing that with me.
No, we were at the G. Rainey Williams conference, which is in Oklahoma all the time. And he was also from Hopkins as well. But the amazing thing, you mentioned Dean Sterianos. His dad was my oral surgery mentor at dental school at the University of Pittsburgh for years. And he was my idol, And then Ghazi Rayan was at the Curtis Hand Center with me as well. And you worked with him as well. So it is a pretty small world.
It is. When you start getting into academic medicine and then academic subspecialties like that hand surgery or plastic surgery or orthopedic surgery, definitely the circles become very small and there's a lot of interaction over time.
Yeah, I really enjoyed it. It was an immense presentation. Thank you so much.
Thank you very much. I appreciate the honor and the privilege of being able to speak to you.
So Warren, it is a small world in academic medicine, but Dr. Morgan knows everyone, even outside of academic medicine. He just knows everyone. I think he was around with Thomas Jefferson also. I always joke with that. He helped build the university. So, but he's a history buff. He knows so much history of this university and just history in general. So he's been a great mentor to many of us over the years. I was a medical student. I was a third-year medical student when I first rotated with him. So, but it's great to see you, Ray, and thank you again for supporting this visiting professorship. It's always great every year. So with that, I think we will adjourn, and Warren, I'll be in touch, and I'll see you in Atlanta next month for the Hand Society Council meeting. Hopefully we can at least get some beers at the hotel bar or something like that. So.
Well, that sounds great. I'm really looking forward to it. And again, thank you so much for the opportunity to share the morning with you and your team. I really appreciate it.
Great. Have a good day.
Okay,
Thank
everybody
you,
have a
Warren.
good day.
Thank you.
Thank you.